for NMCP in Sierra Leone, and she's going to come up and chair our first session. So welcome, Anita. Anita, I'll tell them this one's not working, so if you start here, okay, then we'll get this one going. Oh, it's working now. It's working, so if you want to go here.
Good morning. Good morning, everyone. Welcome to the second day of the digitalization meeting. You're all welcome. Both in person and also virtual participants are all welcome. Today is a happy day for me. Coincidentally, today is my birthday. Thank you. Thank you. Thank you. I will steer the ship from now on to break time, the first coffee break. As already announced, I'm Anita from Sierra Leone. Yesterday, we discussed a lot about digitalization, evidence, and outcomes with various countries sharing their experiences. I think we're going to continue from that stool. We came to realize that digitalization of Bennett campaign using digital tools for data collection, tracking, and monitoring has shown positive outcomes in terms of increased campaign efficiencies, improved data quality, and reduced cost and time. With all the experience shared by countries, if you have not joined the wagon, you need to be thinking about that, because I think that's the way forward. This morning, we'll continue with two presentations before coffee break. The one will be in person, and the other one will be virtual. On that note, I would like to invite Justice Boake of NMEP Ghana. Please take the podium. He will be presenting on Beyond Vouchers, evaluating alternative strategies for item distribution in Ghana. He's going to share his experiences. The next presenter will be online, Chimumso Kim, CRS Nigeria. He will be presenting on the use of e-tokens for item mass campaign, case study of the 2024 Ogun State item mass campaign implementation. He's going to do that online. So, colleagues, please let's listen to what Justin has to tell us. Yes, Justin, you have been invited to the podium.
Good morning. I think she massacred my name a bit. So the name is Justice Boache Yado. Yeah, I think in Ghana for some of the languages, the K and Y is H. Yeah. Anyway, it doesn't matter. Okay. This slide. Okay.
The presentation, please.
I think it's the fault is for me. Okay, so today I'll be talking on evaluating alternative strategies for ITN distribution in Ghana beyond vouchers. So this is the outline of the presentation. There'll be an introduction, why we transitioned from vouchers, ITN distribution strategies that we employed after eliminating vouchers, the new ITN campaign distribution processes, the challenges we encountered, and then the key recommendations. Now, for NMEP Ghana, since 2008, we've relied on ITN campaigns as a core intervention strategy. Now, pre-2018, we were using a paper-based system for our distribution, for our registration and distribution. But in 2018, we transitioned fully from a paper-based system to a digital one. So it was an in-house app that we built. The NMEP ICT unit built an in-house app, which we used. So we piloted that in 4 districts in 2017. So after the success of the 2017 pilot, then we scaled up to 204 districts in Ghana. Okay, so the digitization process was mainly targeted at the registration and distribution process of the ITN campaign. Now, in the previous, in the paper-based one, they were giving out code vouchers to the households. But then with the introduction of the digital system, we introduced a code card. So this is kind of, so with the app, what it does is that it generates a code for the household, and then the code is written on the code card, so together with the person's name and then the community that they belong to. Okay, so at the very top, the green voucher, that was the very first voucher we were using during the paper-based system. And then moving away from the paper-based system, we developed this simple tool for the registration and then the distribution. Now, after the registration was done with the mobile app, we were using these code cards So these code cards were given to the households. So on these code cards, you can see the unique code, the name of the community of the household head, the number of, the name of the distribution point, and then the date of the distribution. So these codes were generated by the app. So the first part of the code was the name of the first three letters of the community, and then the last part of the code was the number of nets that the household is supposed to receive. Okay, so now why transition from vouchers? Now, after the implementation of the 2018 PMD with the mobile app, we realized that there was a high printing and logistic cost. So imagine printing these code cards for, let's say, 16 million households. That's a lot of money. And then also, in procuring these code cards, the procurement process was a bit bureaucratic. So it took quite a while before these code cards were procured. And then also we wanted to cut costs from printing to support the campaign efficiency. Now, after the registration and then the distribution was done, these code cards were collected back, and then they still sit in our district health directorates and then our regional health directorates. So it becomes like a waste of a sort. Also, in addition, during the 2018 distribution, we noticed that a lot of the household misplaced their cards, as well as the registration assistants who did the registration made mistakes on the code cards. So probably if a unique code is supposed to have BED, per the person's handwriting, it becomes B3D or something like that. Okay, so these are pictures of how the codes were used during the distribution. So the household presents the code, the distribution point attendant picks the tablet, and then searches for the code on the mobile app, and then he gives the net out to the household. Now, the new PMD distribution process. From 2021, we decided to transition from using the code cards to just giving the household the codes, the unique codes. So now the digital tool, which was a NetApp, was redesigned to accommodate alternative methods. So now with the new digital tool, it offers 4 options. So they can come for their net with either their national ID, their contact number, the name of the household head, and then the code also. So we didn't take out the unique code, but then we left it there. But then when the registration is being done, for most of them, they give the unique code. They just write down the unique code somewhere. Now in 2024, even better, because we were doing SMC and PMD at the same time, we had done registration for SMC households in 2023. So now in 2024, there was no need to issue new codes to those households. Those households already had their names in our system. They had their unique codes and the communities they belong to in their system. So all what we did was that there was no need to generate any new unique codes for them, but all we did was that we called back the data. For most of them, they already had their unique codes because of their children. We called back the data, and then we updated it to whether they want an ITN or not. So no vouchers or no code cards were used in this process. Okay, so these are pictures of the new approach. So with the new app, a code is generated, but then during the registration, we take the first name and last name of the household head. So we pick it from the ID cards. So for most households in Ghana, majority of us have either the national identification card, the NHIS card, or the voter's ID. For majority of the households, they do. But for households who did not have, they were using the contact numbers. Okay, so with the new implementation, what we did was that we reviewed the digital tool to inform redesigning. Also, we redesigned the digital tool. We developed new training slides and materials based on the changes, and an implementation of social and behavior change activities. So for most of the households, they were used to getting the code cards, as well as the volunteers who were doing the registration. They were used to getting the code cards. So we had to do intensive education to educate them on that. So we trained end users on new functionalities, and then we piloted the new alternative before the 2021 ITN campaign. So once it's successful, and then we scaled it up for that. Now, benefits of the new approach. So we made a significant cost saving by eliminating the need for printing and logistics associated, a faster registration redemption process. So previously, they would have to bring the code card, they'll check the code card, then they'll check on the app whether the code is there. Then now they pick the card and then cancel it and then put it down. So it made the process a bit slower. But then with the elimination of that, it made the distribution faster. As well as even during the registration. Previously, they would have had to write down the first name and last name of the household head on the voucher or the code card. They write down the unique code, the distribution point, as well as the community. But now we had eliminated that, so it became faster. Okay. So we also leverage on existing systems and then governance structures. So we used, because of the existence of these cards, it became easier for us to use it. And then also contributed to the management of the ITN waste. So now challenges encountered and then solutions. Now end users resisted the adoption of the new system due to familiarity with the old process. But then with constant education, they came to accept it. They came to accept it such that we implemented it in 2021, and then for the 2024 PMD also, we were able to implement it. So the new system was somewhat not aligned with the cultural, social, or logistical context of the target beneficiaries, leading to low adoption rate. So this happened during the piloting. But then after the piloting, during the scale-up, they all came to accept it. So now for our key recommendations, we will add, so it was recommended to us that we add an SMS functionality to our GMIS mobile app. So the GMIS over here is the Ghana Malaria Intervention System, which will help send unique codes directly to the households. So right now we are not doing that. After the registration, we don't send the unique codes directly to the households, but then they just write it down. But then in future modifications of the app, we plan to add that, and then include verification of identity using biometric data from the national IDs. Also, we plan to use mobile apps and digital systems to streamline the entire point mass distribution process in an ITN campaign. So right now we are using digital systems at the registration and distribution portion, and then a bit of the logistics side. But then we intend to streamline the entire process from microplan to the distribution. So also it was recommended that we conduct requirements engineering with key stakeholders, including community leaders, before bringing out any new adoption, especially with the elimination of the code cards. So I think I think it was quite pushed on them directly. There wasn't really a kind of discussion of a sort. But then it still worked out anyway. Also, it's recommended that we organize co-designing workshops with community representatives for SBC campaigns to facilitate adoption. Thank you very much.
Thank you so much. We really want to go by the time today. Let's take notes of our questions, read the questions and answer in time. We come up with our questions. We should remember that Justice mentioned why the transition, why do they move from what they have been used to a new approach. Initially, they move to this new approach beyond vouchers, one, because of the bureaucratic inertia in the procurement processes. As usual, any other country is facing that. And also the huge logistics that is involved in printing of the vouchers. You know, there's a huge financial implications in voucher printing. And however, there are few challenges. And these are the, if like any other new intervention approach, we must expect some challenges. But as we go along, based on lessons learned, we are able to correct that, able to adapt to the challenges. And there are also benefits to this new approach. There are also benefits, a lot of benefits. They find out that they save a lot of costs from printing of the vouchers. That's a huge, especially now that we are faced with a resource constraint era. Let me say era. And I think it helps a lot. And also cost saving and the challenges, end users resisted the new approach initially. There is a new approach, but with a robust SBC, they intensify the SBC, especially start at community level for them to accept, to see why this approach should be accepted. I think most of us in our countries have got the ID cards. So when it comes to a question and answer, please, let's ask questions that we think Justice will be able to respond to in case you want to adopt that system in our country. Thank you so much, Justice, for that. Now we go to the second presentation. Chimozo, I hope I'm pronouncing it correctly. Chimozo, are you online?
Yes, I'm online.
Okay, I hope I pronounce your name correctly. So the floor is yours. You're in charge for now, for the next 20 minutes. Thank you, good luck.
All right, thank you very much. Good morning, everyone. My name is Chinonso Chime from CRS Nigeria, and I'll be presenting on the use of e-token for ITN mass campaign, a case study of the 2024 pilot in Ogun State, Nigeria. Next slide, please. So these are our outline. I'll talk on the introduction, background, pilot implementation, challenges encountered, summary of cost savings, recommendations and future plans, and conclusion. Next slide. All right, so ITNs are health commodities in malaria prevention, providing physical barrier against mosquitoes and reducing malaria transmissions. And ITNs are distributed during mass campaigns to ensure widespread coverage, particularly in malaria endemic regions like Nigeria. Nigeria contributes to 28% of the world global malaria burden, according to WHO. And the use of ITNs has been instrumental in reducing malaria morbidity and mortality, especially among vulnerable populations such as children under 5 and pregnant women. Next slide. So the objective of this presentation, the presentation aims to showcase the results and evidence of digitization through the use of e-tokens in Ogun State 2024 ITN mass campaign, And this innovative approach replaces the traditional printed net cards with unique digital tokens, streamlining the distribution process and reducing cost. You know, we are in a cost reduced resources era. So that's the aim. Next slide, please. So historically, ITN distribution in Nigeria relied on printed net card, as you can see above. These are the net cards we've been using, and which were very costly to produce and logistically challenging to manage. It is also worthy to note that digitization of ITN campaign started in 2017. So since that 2017, we've been using those physical net card, unique hologram secured net card. And these net cards we are used to ensure accountability and track the distribution of nets to households. The ITN tokenization strategy that was introduced to address these challenges by replacing the physical net cards with unique digital tokens, as you can see in the slide downwards there. That's a sample of a token that the app generates. Next slide, please. So the pilot scope. The pilot evaluated the feasibility of tokenization as a cost-effective solution for ITN distribution and the need to eliminate printed net card to significantly reduce campaign costs and streamline the distribution process. So this pilot was conducted in 3 local government areas in Ogun State, Nigeria, Odeda local government, Ikenne and Ijebu-Ode. And those local government areas were chosen for their diverse urban-rural profile, providing an opportunity to test the system in varying operational contexts. For instance, Ijebu-Ode is an urban area, Odeda is a rural area, and Ikenne has a combination of both rural and urban area in Ogun State, Nigeria. Next slide. All right, so the implementation process for the e-token pilot. About 13 training and technology administrators were trained and deployed across the pilot's local government areas to support the mobilization teams. So these mobilizers, that's the community mobilizers, the agents that do the household registration, we call them household mobilizers. They participated in a 2-day training program which focused on household registration and token generation. These people were trained in the 3 local governments by the 13 training and technology administrators that were trained at the state level. And about 1,300 booklets of e-token record slips were printed, with each containing 100 slips. I'll throw more light on this later on. And we also, because we have 2 phases of campaign, mobilization and distribution, the distribution teams were also trained on entering these tokens in the mobile app to be able to redeem nets. And then the technology team, also known as the ICT4D team, ensured timely resolution of technical challenges and maintained the integrity of the tokenization strategy to ensure that everything went smoothly. Next slide, please. The operationalization, like I said, in the ITN campaign pilot we did for this e-token, there are 2 phases, the household mobilization phase and the distribution phase. So during the household mobilization, as you can see by the left, the household mobilization team, that's the mobilizer and the recorder, they come to the household. They take details of the members of the household, the number, the details of the head of household, and then a token is generated on the device. This generated token on the device is now handwritten on the e-token slip that was printed and then handed over to the household, and then move to the next household and repeat the process till every household in the settlement and that they are assigned to is completed. Now, at the distribution point, during the distribution phase, the household, head of household, or the women in the house, any woman in the household, come to the distribution point. And when they arrive at the distribution point, They proceed for health education, where they are educated on how to use the net, how to take care of the net, how to ensure that they sleep under the net. After all the education, health education, they go to the recorder at the distribution point for verification, where they present the e-token slip containing the e-token that was generated on the device. And then this e-token is entered on the device and verified, and then they are given the net before they exit the distribution point. This process continues to every e-token that is brought to the distribution point is replaced with a net and given to the household. Next slide. Yes, we have challenges. And we have 4 major challenges. So one of the challenges we had was, one of them is transcription errors. And how did it happen? Because there are 2 teams that were doing household mobilization, we had a case where the mobilizer was calling the code for the co-mobilizer, and the co-mobilizer was writing the codes and thereby writing different things from what the household mobilizer called. Then another challenge we had was legibility issues. We had challenges where the person writing the code, the tokens, was not writing legibly, and it was a challenge. Then another challenge we had was incomplete mobilization. So during the pilot, the app was designed in such a way that the token is generated on the device before you end mobilization. So some household team generated tokens but did not click on complete mobilization, so thereby making the mobilization to be incomplete. It was a challenge we had. Then we also had documentation issues where the households were not documenting correctly. So these are the major 4 challenges we encountered during the pilot, with all the lessons learned that came with it. Next slide, please. So this is a summary of the cost savings. If we were to use the physical net card that we've been using since 2017 in those 3 local governments, it would have cost us $6,630 to procure the physical net cards and move them, transport them, and all the logistics that comes with it would have cost us $6,630. Then the e-token record slip that we use in writing the token was printed for the 3 LGAs with just $647.40. And you might ask, why do we have to still print e-token slip? In Nigeria, we have a lot of context situations. For instance, those in rural environments, many of them does not even have paper to write these tokens or where they can keep record of these tokens. And if you say, let's use SMS, many phone numbers have what we call do not disturb, where they can't even receive SMS. So these are some of the challenges that made us to print e-token slips where the household can record the slips and record the tokens and keep safely for Netcard to redeem Netcard. So from the picture here, you can see that the cost for printing e-token slips outweighed the cost of printing this physical Netcard. So we had a savings of about $5,982.60 by using e-token slip against the physical Netcard, just for 3 local government areas. And in this state, we have about 25 local government areas. And a state like 2025 will be implementing like 6 to 7 states, where we'll have some states have like 44 local government, like Kano State. You see that we are going to have a huge savings by using e-token slip against the physical printed Netcard. So the pilot achieved an approximate of 90% reduction cost from the use of physical Netcard. Next slide, please. So what are the recommendations and future plans? So going forward, only the mobilizers handling the device will write the e-token, and that will help us to prevent the transcription errors that we had initially. And then We are also redesigning the app flow in such a way that you have to enter all the details of the household before token is generated. That will help us to counter the challenge of incomplete mobilization that we faced during the pilot. Then we are also going to emphasize correct documentations during training to also counter the issue of documentation issues, part of the challenge we had from the pilot. Then we are also changing the e-tokens to numbers alone from alphanumeric. In the pilot, we used alphanumeric, and we had issues where people were writing U as V as part of legibility issues. I'm going to show you a sample by the end of the presentation. So we are now changing the e-tokens completely to numbers to reduce the rate of invalid tokens at the invalid e-tokens at the distribution point. Then we are also scaling up e-tokenization in all 2025 campaigns, leveraging the success and insight we've gained from the Ogun State pilot to enhance the efficiency and effectiveness of ITN distribution. Like in 2025 in Nigeria, we are for Global Fund Grant, we are doing 7 campaigns, and these 7 campaigns would happen in 7 states. With Kano being the largest, with 44 local governments. And we are scaling up e-tokenization in all of these campaigns. Then we're also going to consider merging e-tokens and beneficiary IDs as for integrated campaigns, because we also have about 6 integrations this year. So we are also considering possibility where we can merge e-tokens and beneficiary IDs for integrated campaigns. Next slide. So in conclusion, the e-tokenization pilot in Ogun State serves as a compelling case study showcasing the cost effectiveness and ROI, return on investment, of digital platforms in improving health outcomes. So by embracing digitization, ITN campaigns can achieve greater efficiency, reduce costs, and ultimately save more lives. And the success of the e-token pilot in Ogun State also provides a strong foundation for future initiatives, which aims at leveraging technology to improve health outcomes and achieve sustainable development goals. Next slide. This is a sample of the e-token slip that we used last year. You can see it by the left. And this person have a very good handwriting. This household mobilizer have a very good handwriting, but still wrote V as U as the token ID. So when the person that owns this slip came to the distribution point, it came in as invalid token. So this had to be, because the TTAs are the tier 1 technology support at the different wards. They had to reach out to the TTA, and the ICT4D team actually used the name of the household head to get the correct token, because this slip was provided, which was now given back, and the net was redeemed using the correct token. And by the right, we have redesigned the e-token slip to make it in such a way. We now added boxes so that the household mobilizers can write well on the token slip. Next slide. So we did not achieve this alone in CRS. We also had our the partners are the National Malaria Elimination Program, the NMEP. We also have our technology partners, the Red Rose CPS. We also worked in partnership with the state government, the Ogun State government, and also worked well with the Society for Family Health, the implementing partner for the campaign. So next slide. Thank you very much for your attention and for your time. Thank you very much.
Thank you so much, Chimosun. I think I missed the pronunciation. So thank you, all colleagues. All we've had the presentations about the use of e-tokens for ITN mass campaign. He gave us a case study of Nigeria, that something happened in Nigeria. And he also mentioned the process of the e-tokens, the challenges that they face, the recommendations, and the summary he made a summary of cost savings. So I know we have economists here who will have a lot of questions to ask about that. So I want to thank you so much for the presentation. Now the floor is open for questions. Questions or clarifications from the two presenters. Remember the first one we looked at beyond vouchers, evaluating alternative strategies for item distributions in Ghana. Yes, one. Any other? Two? Are we tired today? We have two hands up. 3, 4. Okay, so please ensure that you get your pens and papers ready to write down the questions. Yes, from my left.
Yes, thank you. Thank you for the presentations. My first questions go to Ghana. What measures are in place in order to protect the personal identifiable information collected, such as numbers and also the national ID? The second one is you highlighted significant cost savings by eliminating physical code cards. Can you provide a rough estimate of the cost saving reduction, if available? And the last one is, let me see my note. So what steps are being taken to improve adoption rates in communities where the new system has not been well received? That's for Ghana. For Nigeria, just one question: how has the transition to e-tokens impacted the overall coverage, if there is any, and also effectiveness of the ITN distribution in those 3 pilot areas or LGAs? Thank you.
Thank you. Yes, there was another hand. Yes.
My first question is to the Ghana team. So I think he mentioned that because of the use of this approach, they are no longer doing new registrations for some of the households because they would have already have a unique ID. Can he explain a bit more on this and how that process probably have helped them to either reduce the number of days they are registering or improving or reducing even cost in terms of the registration exercise, since they don't have to do a whole new registration by doing new set of registration for the households? The other question is to the Nigeria team. I think you also presented on the e-tokens or the code cards as we used. I'm just wondering, in terms of accountability, ensuring that people are not printing similar cards and coming over to distribution points with codes that have been generated because they know how the pattern works. Did you encounter any of this, and how are you ensuring that you are safeguarding or protecting the various codes that have been shared with various partners so that you don't have anybody creating duplicate or counterfeit to come to the distribution points?
Thank you. There was another hand. The last table. Yes.
Thank you for the presentation. I have a question for Ghana regarding national ID. Have you been able also to cross-check it with which part of the government maintaining it to validate them afterward, or is it planned? And to also include it if you have any case management system long-term to unify this. And also regarding, no, that will be all. Thank you.
Thank you. On my right, Medad, yes.
Yeah, thank you very much, Nigeria. I have learned a lot from Nigeria being a knowledge bank, considering all their presentations. But I have a few observations. One, you need to think of consolidating all your studies so that you can gain more instead of more pilot and studies. Having said that, I would want to possibly to give me more light on your sample size for the e-token study. Does it give you confidence that you can roll it out? I was part of Ogun distribution campaign, and I saw how the token was bringing more confusion at the distribution points. Then two, what are the percentages of the errored token during implementation that you can use them as part of the lessons? Thank you.
Thank you. Any other arm? I think we have. Now I will allow presenters to respond to your question. We start from Ghana.
Okay. So with your question, the significant savings and rough estimates. Right now, offhand, I can't give you a figure, but then I'll have to check back, and then probably during the break you can talk to me. And then the steps being taken to improve adoption rate. So we only had the adoption rate issue during the pilot. But then from 2021, everyone was okay with it. And then by 2024, that's last year, everyone was already used to doing the registration without the code cards. The first question, I didn't catch it well, was measures in play. I think national ID, something.
Which one is that? The second question? Is it the accountability question?
No, the first one.
It's for Nigeria.
Yeah, the first one was measures that was taken into account in order to protect the personal identifiable information, such as the national ID card and also the phone number or the contact phone number.
Okay. So with that, during the registration assistants don't have access, after they are done registration, they don't have access to that particular data again. They only have access to the first name, last name, and then the unique code to an extent. Yeah, but then they don't have access to that. So all of that is also encrypted on the devices that they are using.
And data are stored locally.
Pardon?
The data are stored locally.
The data?
The data is stored locally.
Okay, so the data is stored on their phones, and then at the end of the day, they synchronize it. But then they don't have access to it locally on their phones. And then the question on the already existing household. So in 2023, we set out to ensure that we don't do re-registration of SMC households and then the children. So what we did was that we made sure that we had a very good register. And then during the 2024 point mass distribution, we noticed that we were going to do SMC and then PMD at the same time. And we're like, why don't we just use those existing households and not create new households? So what we did was that for regions that were doing SMC, there was no need to re-register. So the same volunteer that goes to that particular household to do SMC, that same volunteer has an option to register them for PMD or to just update their details in our system for PMD, whether they want nets or not. And then this reduced the number of days that the campaign was being done. So previously, we would have done SMC differently 7 days and then PMD differently 7 days, being a total of 14. But then it was reduced to 7 because there was no need going back for PMD data. But then in households that were not part of the SMC in the SMC regions, those households were registered for the very first time. Okay, there was a question on the using Ghana national ID to validate. I think I didn't catch that question well.
Medad, is that your question? Yes, the back.
Is the national ID user capture has been validated across the national base, for example? To make it simple, yeah.
Okay, let me try and answer. So what was done was that they just picked the numbers of the national ID. So during the distribution, when they come, they just present their national ID, we search with the ID numbers, and then their names pop up. I don't know if that answers it. Okay. You're welcome.
Yeah, I have a question with regards to Ghana, with regards to the national IDs. Is it that every household member has got an ID card? Suppose you don't have an ID, what did you do?
Okay, so what we noticed was that even though most of them don't have national IDs, a very huge majority of them have voters' IDs and then national health insurance cards. But then in situations where they didn't have any of those, they use their contact numbers. So the ID number wasn't mandatory. Yes, so they use their contact number. So during the distribution, once they mention their contact number, their names pop up. And then we distribute to them.
Okay. Yeah, yes. Yes.
Hello, all right. So just to, I'm Samuel, so from NMEP Ghana. Just to add to what Justice did. So basically, in Ghana, I think for some time now, the government has done well to ensure that both citizens and residents from other countries are able to have access to an identification, one sort of the other. So either you have the national ID or you have the insurance card, or if you're also registered, you are eligible to vote, you have the voter's card. So these became options in addition to the unique code that the Net app will generate following the registration of the household. So what happened was, and then what we realized is, you know, telephone numbers, contact numbers are quite unique. There's no way you're going to have different, you know, households holding similar contact numbers. So all this became part of the information that was collected during the registration. And at the distribution, so all this information were actually captured and stored on the NMEP system. At the distribution, household only need to provide one of these options. And once these options are entered into the system, it then generates the entire information for that household. And you see, and based on that, the distribution point attendant then would go ahead and do the distribution seamlessly. Thank you.
Yeah, thank you so much. Now we go to Nigeria. Chimozon, are you there?
I'm here. Chinonso is the name. All right, thank you very much. I want to be answering the question. So the first question I got was how the e-token affected the coverage rate of ITN. First of all, the Ogun State campaign was an ITN-only campaign, and we had a statewide coverage of 88.11% statewide. That is, we had about 20 local governments, 17 local governments used the physical net card, and 3 local governments used the pilot. And one of the local governments, Ikenne, had 83.55%. The second LGA, which is the most urban LGA, got a percentage of 91.78%, and Odeda got a percentage of 0.01%. So, which shows that the e-token, we are still able to redeem as much net as possible with the e-token. And when you compare the e-token that was mobilized and tokens that was redeemed, you see that the difference is little. For instance, let me use the one LGA as an example. In Ikenne LGA, about 34,918 tokens were mobilized and 29,174 were redeemed, which the difference is not much. Even the most urban area in the 3 LGA, Jebo, they had, we mobilized 43,167 tokens, and about 39,621 tokens were redeemed. Then coming to the second question on the accountability of the printed, the e-tokens that we did. If you go back to the slide and see the sample of the e-token slip that I showed, the e-token slip is actually serialized, and we also used a unique type of paper to print it that you can't easily photocopy it, and it's also colored. It will even be very expensive to print colored to just go and reprint colored tokens here in Nigeria. So we've ensured that the token slips, that the tokens we are written, we are serialized, and we used a unique type of paper in printing it, and yet it is affordable. For those 3 LGAs, it just costed us about $647. And the third question is the confidence of us scaling up on the e-token. We've piloted this in different rural and urban contexts. We have both rural area, rural urban area, and that is the fact that we tested it in different scenarios shows that we can actually scale it up. And we've also learned lessons, which are the recommendations that we are implementing. Like I said in my presentation, we are redesigning the app flow in such a way that some of the challenges we had initially, we are not going to have it when we scale up. And this was a pilot. Lessons are learned every year. By the end of our campaigns in 2025, we are going to innovate more, improve on what has already been done. Thank you very much.
Okay, thank you. We'll take a last round of questions from the floor. Any burning issue, any clarification based on the 2 presentations? Any questions? We look tired today. We want to go in. Please ask questions. These are very interesting, insightful results from these are new approaches that's it's only when you understand the concept, they're able to adapt it if you want to adapt it. So please, let's ask them questions. Whatever you think is not clear, we'll ask. And they will be here to explain. Yes, I have... Come again.
Well, since you're asking for questions, I will ask a question. So I guess it's for both presenters. There is a possibility, and I think you have both mentioned, that you will have households that do not have an ID card or a national recognized ID card, and you will also have households that will not have an ID card or a mobile phone number. And these usually represent some of the most vulnerable communities. And being in the humanitarian field, I think it is our, let's say, duty to make sure that they are, they are reached with our interventions. So, but I just want to know whether either one of you had thought about how, I know we can give them a printed token or a printed piece of paper with just a generated number that they can then use to redeem nets. But have any of one of you thought about how digitalization could in future be adapted so that it can also benefit these populations, these vulnerable populations? Over.
Thank you. Yes, please.
Good morning again. Thank you very much. I have a question for Ghana. I know because of previous registration, you say some households are not going to be registered because they fulfill all the requirements. But what happens when a household moves from where it was when the registration was done? I'm asking because when a household is registered, we have the community where they should go or the distribution point to redeem the net. What happens when that household moves from the original residence to like the city? Let's say it was registered in zone 1 and now it's now in zone 3.
Okay, thank you. Yes, please, at the back. Have you taken note of that?
I have a question for Nigeria. I believe you mentioned that the e-token pilot had about a 90% cost reduction. so something like $6,000 to $600. I was curious if that was incorporating all of the costs, including like the training and the technology development and all of that, or if that was mainly focused on the printing cost and the reduced printing costs versus the original vouchers. Thank you.
Thank you. Yes, please, the front table.
Yeah, my question is, apart for, there's no more, doing another registration for the subsequent year, once we provide a unique code, apart from family move from one another place to another, but we African, we tend also to have more children. Sometimes the number of family increases, and we have the same unique, I don't know in terms of how are you going to resolve the number of items also. People sometimes die, sometimes they have a lot of issues around the families. How are you always try to solve them or encounter them during the registration? Thank you.
Thank you. Any other? I think we allow them to answer. Yes, Ghana.
Okay, so with a question on households who do not have either an ID number or a mobile phone number. So with such households, in those rare situations we had, what we did was that sometimes in that particular village or community, for most of them, there's a particular contact that they use for all their calls. Probably for the entire village, there's this one contact that they use. So those contacts were put in there, but then aside using the IDs and then the contacts for the distribution, a unique code was generated for them. So during the distribution, they just had to present the unique code. There was no need for them to come with their contacts or anything of that sort. And then the next question is, what happens when households move from where the household is registered? So I think that one is in connection with SMC mainly. Yes. So during SMC, what happens is that for households that have moved, what we do is that when they visit the household and they tell you, and then the household tells you that we were in this particular district and then we've moved here, or probably when they search for the code and they realize that he is not in that particular community. What happens is that in the system, they are moved from, if they're in community A, they are moved from community A to community B, so that that particular district or community will have access to those households. Okay, and then the updating of households. So what happens is that, so this is the first time we are doing the reuse of the SMC data. So what's happened during last year's point mass distribution was that since in the SMC we don't take the total number of people in the household, but just the number of children. What we did was that during the distribution or the registration, we made them update the number of people in that particular. We made them update the data with the number of people that existed in that household. So probably in future registrations or future updates to the application, what we will do is that we'll make them take the details of every single member of the household also in conjunction with the children also. Yeah. I hope it answers their questions.
Okay. Thank you. Is that all?
I think.
There's another question. Yes.
Just a following question regarding the updating the unique. Are we sure that in Ghana or in the rural village are having internet access? Because what I believe from the system, when you want to update, the system need to pull the data from the system. And you are in the village already, you want to improve, you want to update the data. And the internet connectivity is not there. What do you do?
So with our system, what it does is that before the registration assistant set out, they pull data, let's say they synchronize the data or they pull the data that's already existing to the tablets offline. So they log in, they pull that data, and then they move into those communities that do not have internet connectivity. Yeah.
Okay. I think we have a question for Nigeria. There was a question for you.
Yes, yes. Can I speak on? Can you hear me?
Yes, loud and clear.
All right. So the first question was asked to both me and Ghana on how we use digitization to reach rural areas, especially the vulnerable people who don't have phones and all. So our mobile apps are designed in such a way that they can work offline, whether they are mobile network or not. And then at the end of the day, we have what we call synchronization spots, where the household mobilizers know that there is mobile network and they come there to synchronize their device. Now, at the help desk support, we use geospatial analysis to monitor areas using the state map to know areas that are covered and areas that are not covered. And we also target those rural areas to ensure from the map that they are all covered. And we also, during daily review meetings in the evening, we try to look at the coverage of the state, not just in numbers, but on the map, to ensure that every area of the state is covered. Then areas that are not uncovered helps us to know where we are going to do monitoring the next day. Sometimes we go to those rural areas to do monitoring and now found out that, hey, these people have been mobilized, just that maybe their data has not been synced. Then we now encourage the household mobilizers to identify sync spots and synchronize their phones. So this is how we ensure that every area in the state is covered. Then the second question that was asked to Nigeria on the 90% cost reduction. The cost reduction was particularly on the net card, and it had no effect on the training. We leveraged on the existing structure to pass on the training. So it didn't have any cost effect on the training. It's just on the net card, physical net card, and e-tokens. Thank you very much, and over. Thank you.
Thank you. Thank you so much. If in peradventure we still need some more information, now that Justice is here, you can meet him or the Ghana team, meet at any point in time if you need further information. And also the Chinosum. If we have questions, we post the questions to you. Maybe there are more issues. So I think now we can end this session. Thank you so much for your contributions. Thank you for participation. It's time for tea break or coffee break. We have 50 minutes? 30 minutes. We have 30 minutes tea, coffee break, please. Thank you very much.
Sanru to come up, and he will be leading this next session. He may have just stepped out. There he is. So I'm going to hand over to Dr. Joris, who will introduce the session and then invite up the panel members. Thank you.
Merci. Bonjour tout le monde. J'espère que on a retrouvé des forces avec la pause café tout à l'heure. Nous allons donc continuer notre dernière journée. Je pense que c'est peut-être un peu lourd pour ceux qui étaient là depuis le lundi, mais encore un peu de courage.
Le micro, ça marche pas.
Merci. Donc voilà, on va donc commencer cette série de l'appropriation et la durabilité des approches de digitalisation. Depuis le début de la semaine, on a vu beaucoup d'initiatives d'innovation et beaucoup de choses qui sont réalisées dans beaucoup de... On va essayer de voir des questions de gouvernance, d'appropriation et de durabilité. Et pour ça, nous allons avoir l'équipe du Kenya qui sera présentée par James Mwangi, que j'invite à rejoindre le podium. Pendant que James approche, je souhaiterais que Rodrigue du Bénin monte également. Ils vont faire leur présentation successivement avant que l'on ait une session de discussion, questions et réponses. Donc voilà, la première communication portera sur la gouvernance, appropriation et durabilité des approches de digitalisation pour les campagnes de santé publique. C'est une bonne communication introductive de cette session. Donc, je vais inviter tout de suite James Mwangi à faire sa communication. James.
Good morning. Good morning. So from your program, I am not Andrew. Just a disclaimer. I'll be presenting Andrew, Team Kenya. Team Kenya, you can wave from wherever you are. So those are the owners of the presentation. Thank you. I think I'll move on straight. So my presentation is around governance, ownership, and sustainability of digital approaches for public health campaigns. And I'll delve more on the Digimal KE. I think this was presented yesterday, why we got to use the digital platform, Digimal. Next slide. So it's a snapshot of the burden in Kenya for malaria. We have the Western Kenya, that's why we have the highest burden. And Northern Frontier, we have a called Turkana, where we are now experiencing high cases of malaria. So the coastal region. The map, initially there's been progress, but with the measures in place, very as it used to be. Next slide. So for introduction, Kenya has made various progress in terms of digital transformation in the country in terms of health. Both their legal and policy guidance within the Health Act, that is 2017, and also within the health policy. So it's well stipulated and gives the direction the country has taken in terms of digital transformation. In terms of overview of digital transformation in the public health campaigns, I think in 2023, Kenya did the MassNet campaign, which was almost end-to-end digitized in terms of the activities all the way to distribution. That is the last mile. And then also we have had a stint in mass drug administration in 2024 for NTDs through the electronic community health information system. The importance of governance and ownership and sustainability, it's around ensuring there's the regulations and coordination, and then ensure that there's accountability, compliance, and efficiency on any drug digital platform. And then global guidance and all-inclusive country-led processes, just ensuring that the country owns the whole process. Then technology adaptability and resilience. Next slide. So in terms of government and policy, the Digimal KE, we ensured there was compliance with the Kenya Digital Superhighway, which leverages on the existing digital technologies. And then it's all geared towards improving, service delivery to help the country achieve its agenda of universal health coverage and also to address the SDGs, which all of us are working towards ensuring that we achieve that. And then Digital Platform, in terms of alignment with national data protection regulations, we have both internal and external data protection assessments. So we ensure that the Digital KE was well aligned. Then there was the role-based access control so that you're able to regulate and understand, or rather control who accesses that data, because we are cognizant that data must be protected. And then there's that continuous platform monitoring to ensure its performance, it's well aligned. And in terms of stewardship by the malaria program, Digimal was geared, the leadership of the Ministry of Health took charge of it. There was a plan of action to be implemented. There was a steering committee that met regularly and usually to review the progress of the use of the Digimal. And if there are issues and challenges, there's always an escalation process from one level to the next. Sorry for that. On this slide, I'm going to look at the various components and how Digimal is open for being used in a public health agenda. So in terms of the various components that are easy to can be deployed in any health area. So when it came to personal registration and management, and I know in any health campaign or any health area, there's need for you to have, a database of all persons involved in the campaign. So the Digimal helped in terms of data capture and validation of the various people who are going to the system, from the policy makers all the way to the health promoters who are the key users in terms of distribution, and also in terms of the various hierarchies. So there were partners and sub-county, the various hierarchies in Kenya. Then in terms of all those who are registered, they were aligned and roles assignments. So every person in the system had a role, and so their usability was well defined. Then those who are registered were able to access the system either through SMS, USSD, and the web-based platform that existed. Platform. I think this was well explained yesterday, where we had a base USSD platform was the main area where we use the Digimal platform, but also it could be accessed the web platform. In terms of engagement management, there are we defined various activities and events. So an activity is an act where people are going out there, like supervision, we call it an activity, but an event is where people are sitting in terms of like when you're doing trainings. So all those, so we're able to define the persons and their roles, location, and the date in terms of when they are supposed to perform a certain activity. Because any event and activity, there was a hierarchy of who initiates a process. So if you're doing training, you cannot start training until the date when that training is assigned to happen. And there are those who are assigned to do that role. Then all this helps in terms of informing the payroll. I know we have had various challenges in terms of delayed payments, but this system was able to help in terms of informing a payroll which was generated, and it was linked to mobile platform money, where in the click of a button, people are able to receive money real time. So this is in terms of how we engaged. And then mapping and alignment. Of course, there are various administrative units, drop-off points where nets were being dropped, and in terms of the distribution. So the Digimal KE platform provided specific visualization. So if you're at national level, there's information that you're able to see. At county level, there's that information you're able to see. If you're supervising the community health promoters who are doing the household registration, there's a specific information you're able to see. And I remember even at national level, our permanent secretary, there's a dashboard that we're able to see specific to them. Then Digimal was linked to LMIS. We have Kenya Medical Services Authority that distributes the commodities that was distributed the nets. We're able to link the Digimal platform with that system. There's a MEDS that distributes commodities on behalf of what distributed the USG supported commodities. So they were able to link to that system. And then it was able to inform in terms of performance. You're able to judge in terms of how the system was performing. And in terms of registration, there was a beneficiary registration, which was done either online or offline. For online registration, we were using the USSD platform, so where a community health promoter just used their own simple and there was power, and we are back. So, sorry, I have to go back. I think I can use this. Thank you. So in terms of registration, there was the online registration that was use of USSD, where the community health promoters were using their simple phone, the feature phone, to capture the details of the household head and all the characteristics that were collected in terms of how many people are in a household, so the contact details, the household population, how many people are in that household, and then they could also pick the collection point because the system linked your registration to your collection point. So if you're from a particular village, you are allocated to a post that is a fixed post that is closest to you. And then there was real-time visibility of data, and this is whereby by the end of any particular time, we were able to see whether all the community health promoter had started registration. One of the gaps which has always been there is tracking real-time registration. And we had CHPs who had challenges, and it's only through the system that you're able to see after several hours, some households have not been, villages have not been registered, and there's no data that is aligned to that CHP. And so it helped in terms of ensuring that there is, the support supervision was conducted, and the support that was required by the CHP or the community health promoter was given. Then, in terms of the commodity management, we had an inventory module in the system, which was, helping in terms of deciding the number of nets that were to be allocated to each household, and that built all the way to how many nets were required in a certain drop-off store. So this was near to accurate, and in case where there was also a flag in terms of there could be a flag, any allocation of household that has been allocated more than 5 households. This was flagged to the supervisors so that they can follow up and ensure that it's either there's no typo or in terms of number that has been indicated. I noticed some presentation yesterday they were talking about fraud or just accidentally there's a typo. So that is corrected real time. And then all orders were processed and fulfilled through the system, because that once the data has been captured in the system automatically allocates the number of nets per each household based on the universal coverage, and that information is also aggregated, and it informed how many nets were required in a certain drop-off store and at a particular post where those households are linked to. In terms of distribution, we had database for all the fixed points that were distributing the nets. There were over 12,000 or thereof, and then there were beneficiary identification. So in terms of each household was supposed to present their identification document, and once that document, identification details are entered in that feature phone, the details of number of nets that have been allocated and the post were, they're able to see. And the same message of number of nets that have been allocated had also been sent to the household. So it ensures there's that, accountability in terms of how many nets have I been allocated, and does the system speak to the same. This ensures that nobody received the less nets than they have been allocated. Then we are able to have real-time visualization of distribution. Again, if there's any delay in a certain post, you're able to identify that because data is not flowing. Data was flowing per post when it came to distribution. And so if a distribution post did not have any data, that's a point where it informed a lot of supervision. And then, in terms of reverse logistics, this has always been a nightmare in the previous campaigns. You're not even able to know how many nets have been left in a certain post. This system was able to do that, and where there were gaps in terms of maybe nets have not been collected on somehow, nets were allocated and there are leftovers, there was a process that informed the reallocation of those nets. And then, user and payroll management, the Digital KE was able to help in terms of managing the campaign personnel, where there was user profile and account. So if you went to the system today, you can be able to see how much a person of the Ministry of Health who was supporting was paid. So there's that information that you can go and verify. Then there were multiple levels of approval. So the first approval is at where an activity or an event is happening. Once that is approved and there's evidence of attendance and participation, then there's an authorization at the highest level, first at a lower level and then highest level. And once all that process has been done, the National Malaria Control Program head was able to click the pay button, and in few seconds, money was trickling into the mobiles of the user. So it really enhanced that whole process. So the linkage to the mobile platform worked very, very well. And so there were no delays in terms of payment, which previously has been the situation. So when you look at all these parameters, if you're doing any health, any public health activity, this is a system that it's very easy to adopt and follow. So overall, after using that system, this is what you see the moment you log into the Digital KE platform. This is your landing phase. So we started, I think should have put the screen when, the dashboard when we started, we distributed the first net. So you can imagine we distributed over 14,000 million nets. So you're able to see how many nets were delivered, how many were distributed, and what is your percentage in terms of performance, how many households had you targeted, how many received this, how many came to collect the commodity, and how many were served. And if you break it down, you can be able to see the various counties, the 22 or thereof counties. You can be able to drill down to the lowest level, and you can be able to follow up and find out which particular village or post was affected, and there was challenges in terms of distribution. So for this was at national level and everybody can use this, but also there were other dashboards that were very, you remember we talked about access. So if I worked in a certain county, if I log into this system, I'll just see that county. I'll not be able to see this unless I have an interest. So the performance of Kenya, we were able to measure this. Yesterday, I remember someone saying they were talking about if you need data, ask the supervisor who will ask another person. Now you don't have to do that in Zanzibar. You have just to go to the system and be able to see that all that information. It becomes very easy. Then in terms of country ownership and sustainability, so the Digital KE was locally developed with university-based developers, the University of Nairobi, with the support from USG. I think we can appreciate PMI in their absence. A clap for PMI. So with partnership, of course, with Global Fund, so this is how the system was developed. It was built on open source technology for usability and integration, so it's very easy to integrate this system. Then it has low device requirement, bring your own device model, for wider accessibility. You see, when you bring your own device, I'm sure we'll have more conversation on this. The CHP, who are the greatest users of this system, they are bringing a phone that they are used to operate. So you're not teaching them how to operate. So that's already taken care of. Majority of them, because of the mobile platform, they have the mobile payment. They have their phones, which are very easy to use according to them, and they understand their phone. So this model worked very well in Kenya. And so this is for USSD. And then where there were challenges in terms of the network, we deployed the smartphones. Lucky enough that for electronic community health information systems, they have provided smartphones. So we use the existing platform, gadgets. You remember, we are very aligned to what's happening with the digital system. So we are able to use that. There's no time someone bought a phone to use it for this system. Then we had materials that were developed, training materials on virtual academy. In our Kenya Health Information System, we have a virtual academy where all these materials were uploaded. So at time of operating the system, there were materials available for a community health promoter, for a supervisor, anybody, anything that you needed to know, plus the standard operating procedures, they were all captured there. So even as we speak, and if you're going to implement the same system in 2027 during distribution, these materials will still be available. And you can still have many people interacting with the materials so that they're able even to know how to operate the system. Then for integration and scalability, for campaign execution, there was the beneficiary registration. I think I explained on how they were registered, visiting the household and ensuring you collect the correct details. Then there was a service delivery tracking and reporting the system. I think I did talk to all that. And then inventory management and distribution oversight, where we are able to look at the commodity and ensure that there's accountability of commodity. I think the performance of this in terms of how over 90% of the commodities, you could be able to track them from the central warehouses all the way to the last mile. And then there are various notifications in terms of if a household has been registered, there's a notification that registration is successful. And it's only that can we know that a household has been registered. So there are all these notifications that had a role to ensure that no one is left behind in terms of registration. If there's any requirement on the system, mobile, an SMS, short message was being sent. In terms of coordination management, there were real-time dashboards for monitoring and evaluation, so we are able to do so for those health, the supervisors, and anybody who was interested in the campaign, from wherever you are seated, you're able to see the dashboard and the performance in terms of registration, distribution, even payments. Then data warehousing for comprehensive reporting. So there's a lot of data that has been stored which is available, and perhaps it can play a role in terms of the future campaigns or any other campaign, as I'm going to show in a later slide. Then human resource data capture, including referencing other systems for HR information. Remember, you're using an ID to register people. Payments were being done by job group. So we had a system, a HR system that was linked to this. So if you're James Mwangi, if I log in into your details into the system, I'm able even to get your job group. So I don't have to bother asking you about your job group, so that I'm able to know how much you're being paid. Same case for CHPs and the rest. And then for payroll for payment of campaign staff using integration with mobile payment platform. So we were using the M-Pesa. That is the famous in Kenya, but there are others, and I'm sure in the process we'll continue to see how we can work with the others. Then the technology, I did mention, it's open source, and the API is ready to be linked. So we were able to link to the ERPs used for logistics. I mentioned the Kenya Medical Supplies Agency and the meds who are distributing the ITNs. And then there was the expenditure reporting that was being summarized. And even now, if you want to, in terms of follow-up, in terms of payments, there's a report that you can be able to access. On impact and governance and decision-making, so there were real-time dashboard at all campaign levels. So at national level, at county level, at sub-county level, at ward level, and even at village level. There was all that information. Then just to ensure there is accountability and efficiency, there was also transparent tracking of personnel, performance, and commodity. So for those who participated, they're able to log in into the system. If you're being trained, you have to log into the system. So you cannot log in if you're not in the training, because there was a special code that was being given if you're in a training, and that was only done during that particular activity or event. So you're able to know the personnel who participated for how many days. Like for supervision, if it was for 5 days, we're able to track if you logged in for 1 day, 2 days, or 3 days, and you're able to, to meet your obligations. For commodity, it's the same. If 1 million nets have been dispatched from the central warehouse, you're able to track all those nets all the way to the end user. Then time-stamped records, ensuring accountability. So if there were things that could have been changed in the system, of course there was a process, there was standard operating procedure for changing some details. Assume my identity was captured wrongly, there was an option of that changing. However, there were logs, we could track and know who changed those particular details. So that helps in terms of accountability. Then there was a prompt system with multi-level approvals and built-in validation. So I remember we were seated in the National Malaria Control head, and it was like he clicked a button and people who were in that room, they got paid instantly. So it was one of the best systems that we witnessed in terms of payment. So lessons learned and future recommendations. So for scalability, a larger pilot needed to reduce deployment issues. Kenya did a piloting in some 2 villages. So we targeted a very small number, and I think when we are now, scaling it up, there are those challenges we did not anticipate. So the recommendation is do it in a larger scale, so that you're able to address all the issues. Then data readiness, for the system to work, of course, we had to collect data for all the people who are participating in the campaign. So that data has been collected and then uploaded into the system so that we can have a master list. So there were challenges in terms of not all data came in time, and then it needed to be cleaned. So if you do it near to a campaign, it's going to have challenges and may cause a delay or challenges when you're implementing. Then interoperability, we are leveraging on existing data set for validation. So like you're talking about a population of a certain county, do you have that system? If you have any other data in the system that you can corroborate so that you're able to validate, so that you don't register and only discover that your population is way above what you are anticipated, and maybe that the data you had used to to project the number of nets required. So we have electronic community health information and any other data in the KHIS that you can use to collaborate. We have annual work plans for counties. We're able to corroborate that information so that as registration data comes in, you're able, because most challenges that we experience are during registration, whereby numbers can be ballooned or numbers are more than what you had procured for distribution. Then scope management, sticking to define features while staging enhancement. So it's just be open to change. So when you're out there, when you're implementing, you discover something is not working and there's a way you can enhance it. So the developers were on standby so that if there's anything that you need to enhance, it was done real time to ensure that the activity continued, seamlessly. And then adaptation, looking at other delivery programs and pathways. Can this be used for SMC? We can link this system. So we're looking at Digital KE. We can link it to other, other programs, SMC, IT, continuous distribution of nets. Perhaps that's something, and that is what Kenya anticipates to do, so that you're able to link the same household that were covered during MassNet. If you're doing continuous distribution, you have database you can always refer to. If you're doing indoor residual spray, it's the same platform that you can be able to use. So in conclusion, we had committed leadership, and if you have leadership that's committed, it ensures you are well aligned to the national health priorities, and also you're able to secure policy backing, because there are policy changes that had to be done to ensure that the system is accommodated, and then receive continuous investments for sustainability. You need resources, and who are the people who allocate resources? It is the leadership. So you have to be well aligned. Then have resilient and adaptive technology platform. Ensure that there are those issues that are backbone of a system in terms of data collection, real-time data collection. If you're talking to anyone, they'll ask you, will I see the results real-time? Secure and transparent decision-making, and then seamless integration platforms like Digimal. They can evolve to meet emerging public health needs. I think I demonstrated how Digimal is ready and can be used for any other health need. Then community acceptance. I think this is something that was even discussed yesterday. Engaging local stakeholders is key, so that you don't take to them a system that's not easy to use. So ease of use is very important. Then addressing digital literacy barriers, ensuring like now the training materials that you have, are they customized for various, the way a health worker will understand the training material is not the same way a community health promoter will understand it. Then enhance trust. People have to trust the system you're working in. Is their data safe? Who accesses the information? Then adoption, and it has to be, of course, reliable. So Digimal met all this. There's a sustainability aspect, in scalability and impactfulness. So when you're looking at a system, you should be able to have, ways how that system is sustainable. Is it easy to scale? If you want to do any other work on what is the impact for Digimal, 14.9 million distributed, it was not an easy task. So what is that impact you are creating? So there's someone who said, every once in a while, a new technology, an old problem and a big idea turn into an innovation. I think it was the challenges we faced through previous campaigns that we had to come up with a solution, and there it is, and the success is there to be told. And I'm sure most of you have presented on the successes of the digital innovation. So thank you very much for listening.
Merci. Merci James pour sa brillante présentation qui nous a présenté les chemins parcourus par les Kenyans depuis la mise en place des directives et des politiques jusqu'à la réalisation de ces importants résultats. Nous allons donc inviter Rodrigue pour nous faire la présentation des solutions intégrées pour les soins communautaires et les campagnes nationales au Bénin. Rodrigue.
Merci beaucoup. Merci beaucoup, cher facilitateur. Bonjour tout le monde. Je suis Dr Rodrigo, conseiller technique du ministre de la Santé du Bénin aux soins de santé primaire et président du comité de pilotage de la mise en œuvre de la nouvelle politique nationale de santé communautaire. Nous allons, au cours de cette présentation, partager l'expérience du Bénin d'une solution intégrée pour répondre aux défis de l'organisation des campagnes de masse, mais également des activités de routine. Ça marche pas. Donc, pour cette présentation, nous allons parcourir essentiellement 3 points. L'expérience du Bénin avant la digitalisation, et qu'est-ce que la digitalisation nous a apporté et comment la nouvelle politique de santé communautaire a révolutionné l'organisation des campagnes de masse, la plus-value que cela a pu apporter. Nous finirons par les défis et les perspectives que le Bénin envisage sur l'utilisation de cette solution digitalisée. Comme à l'instar des autres pays, on a plusieurs programmes de santé qui organisent périodiquement, je dirais chaque année, des campagnes de masse pour pouvoir atteindre les cibles. Nous avons le programme du paludisme, le programme de lutte contre les maladies tropicales négligées, le programme élargi de vaccination, et mais également, nouvellement, le programme de la nutrition qui organise ces activités de masse pour soit la distribution des intrants, soit la vaccination des populations. On a constaté que ces campagnes font appel à des acteurs communautaires qui sont, avant 2020, des acteurs non spécifiques, avec des résultats plus ou moins reluisants, surtout pour ce qui concerne la marche avant 2020. On constatait que essentiellement, les couvertures administratives qui sont enregistrées au jour le jour sont nettement en déphasage avec les couvertures d'enquête, et donc il se posait le problème de la qualité de l'organisation de ces différentes campagnes de masse. Donc nous allons voir que au niveau du pays, avant 2020, on avait plusieurs insuffisances au niveau de ces campagnes. Déjà, le défi, c'est de s'assurer que le travail se fait très bien. Les relais communautaires, les acteurs communautaires qui étaient sollicités avaient un défi de compétences qu'il faut résoudre. Il y avait une bonne charge de travail parce que la plupart, c'est des outils manuels qu'il faut renseigner. Et lorsque vous prenez ces outils, vous voyez qu'il y a plusieurs manières de renseigner. Il y avait des insuffisances, soit un mauvais remplissage ou même une mauvaise compréhension des directives et des consignes. Lorsqu'on organise les campagnes dans ces conditions, il y avait un faible suivi au niveau de la communauté, parce que vous n'êtes pas assuré de savoir ce que les acteurs communautaires font au quotidien et parfois instantanément. On déployait des superviseurs, mais leur emprise sur les acteurs communautaires était assez faible, ce qui générait comme conséquence, vous finissez la journée d'une campagne et vous attendez peut-être le lendemain pour que les données vous parviennent de façon parcellaire. Vous ne pouvez pas analyser instantanément pour savoir est-ce qu'il y a une bonne progression, est-ce que les ménages sont bien couverts, est-ce qu'il faut réorienter les équipes, est-ce qu'il faut ajuster les consignes. Donc c'était un flou vraiment total. Et donc à partir de 2020, on a fait les premières expériences de digitalisation en utilisant l'ODK. C'était Red Rose qui nous avait accompagnés. On a organisé une campagne nationale de distribution de moustiquaires avec ce système digitalisé, puis après d'autres campagnes, notamment les CPS et les campagnes ONCO. On a constaté nettement qu'il y a une amélioration au niveau des résultats, mais il persistait toujours ces insuffisances et défis, notamment comment s'assurer de la bonne couverture des cibles, comment surtout s'assurer qu'on a les informations qui sont bien implémentées sur le terrain. Et il y avait un défi très important, c'était que vous finissez la campagne et vous attendez peut-être 2 semaines, 3 semaines, 1 mois pour avoir les pièces justificatives et procéder au paiement des acteurs, et puis cela pouvait générer des remous. À partir de 2023, le gouvernement a placé la santé communautaire comme l'une des priorités phares de son action, et on a designé une nouvelle politique de santé communautaire qui a été digitalisée. Depuis, cette politique est utilisée pour organiser toutes les campagnes, que ce soit pour la moustiquaire, pour la distribution des intrants, pour la vaccination, mais également les activités de routine au niveau communautaire. Et nous avons constaté qu'il y a eu une avancée vraiment notable, surtout pour ce qui concerne les résultats. Vous avez les données agrégées de couverture, et lorsque vous faites une enquête, ces données sont superposables. Donc, il y a moins de ménages qui étaient sous couvert, et surtout, nous avons une meilleure compilation des données de façon prompte, de façon complète, qui permettait à ce que tous les acteurs à tous les niveaux puissent vraiment suivre les résultats et prendre les décisions qui s'imposent. Et puis, il y a également une innovation d'introduire le paiement des acteurs dans cette digitalisation, et ça a permis à ce que, lorsqu'on organise une campagne, le lendemain, les acteurs pouvaient être payés et avec beaucoup de satisfaction. Qu'est-ce qui nous a permis de faire ça? C'est une plateforme qui a été développée en collaboration avec Dimagi, qui permet à ce que les acteurs communautaires, qui sont de 2 ordres, les relais communautaires et les agents de santé communautaire qualifiés, qui sont des infirmiers, qui sont positionnés dans la communauté, puissent utiliser une tablette pour pouvoir faire la collecte des données, envoyer des alertes de façon instantanée, que ce soit des alertes en matière de santé, mais également pour tous événements de santé publique. Ça permettait l'utilisation de cette plateforme, permettait à ce qu'on puisse disposer des données de façon instantanée, et qu'une alerte communautaire qui est lancée puisse mobiliser les acteurs qui doivent apporter les réponses au niveau opérationnel, mais également au niveau national, pour pouvoir ajuster les décisions, prendre les décisions qui s'imposent. Et donc, ça permet à ce qu'on ait un meilleur pilotage stratégique depuis le niveau central jusqu'au niveau opérationnel de notre système de santé. Au niveau de cette plateforme, nous avons essentiellement 3 acteurs qui sont impliqués dans l'utilisation au quotidien de cette plateforme. Nous avons d'abord les relais communautaires. Au Bénin, avec cette politique, vous avez un relais communautaire qui s'occupe de 200 ménages de façon permanente. Donc, dans sa tablette, il est embarqué les données de ces 200 ménages, qui sont les membres de ces ménages, quel âge ont-ils, quels sont les problèmes qu'ils ont. Et ça permet à ce qu'avec les modules qui sont développés au niveau de cette plateforme, de former le relais communautaire, mais également qu'il puisse mener ses activités de routine, que ce soit des activités de prévention, de promotion de la santé, mais également de remonter des alertes d'information pour que s'il y a un membre du ménage qui a besoin d'être pris en charge ou qui a besoin d'un intrant spécifique, que le niveau hiérarchique immédiat puisse se saisir de son problème et apporter les solutions qui s'imposent. Le deuxième acteur qui utilise au quotidien cette plateforme, c'est l'agent de santé communautaire qualifié, qui est un infirmier placé dans la communauté, qui a à charge entre 20 et 40 relais communautaires. Et donc au quotidien, il sait ce qu'un relais communautaire est en train de faire, il le suit, il peut organiser une supervision sur site pour voir comment il mène ses activités, mais également les réunir à la fin de chaque mois pour mesurer leurs performances, les accompagner, les former. Et il y a des modules spécifiques qui sont développés au niveau de cette plateforme pour lui permettre de mener ses activités. Et en plus de ça, lui, lorsqu'il reçoit les alertes du relais communautaire, par exemple un enfant qui est malade, une personne qui a une hypertension, et ainsi de suite, cette alerte est traitée à son niveau. Si c'est une maladie qui peut être traitée directement dans la communauté, il va dans le ménage, il apporte la solution parce qu'il a capacité pour... S'il ne peut pas faire la prise en charge dans la communauté, il envoie ce malade, il l'oriente vers le centre de santé, il alerte pour qu'il puisse recevoir les soins qu'il faut. Et puis, au niveau supra, dans chaque département, il a été positionné des IT qui sont des gestionnaires du système qui permet non seulement la gestion des données, l'export des données, mais également apporter son support technique lorsque les ASCQ ou les relais communautaires ont des difficultés, soit des bugs au niveau du système. Nous avons... Excusez, la technologie ne marche pas. OK. Très bien. Est-ce qu'on peut m'aider? Voilà, c'est bon, c'est venu. Et donc, lorsqu'on voit dans le paysage béninois l'utilisation de cette plateforme, ça a été pratiquement une révolution qui a été apportée, avec le soutien politique, l'engagement du gouvernement à faire de cette plateforme le cœur du système communautaire et de toutes les interventions qui sont organisées dans la communauté, que ce soit au niveau du secteur santé animale comme au niveau des autres secteurs. Et ça permet aujourd'hui que, de façon instantanée, on puisse apprécier la performance du pays pour chaque intervention qui est menée. À titre d'exemple, nous avons fini hier la campagne ONCO pour cette année et aujourd'hui, non seulement on a les données, on a les performances au niveau de chaque contrée du pays, mais les acteurs communautaires qui ont mené cette campagne sont en train d'être payés déjà aujourd'hui. Et nous avons comme ambition d'intégrer, on développe actuellement avec Dimagui, le volet paiement des acteurs pour les activités de routine. Parce que les relais communautaires, les agents de santé communautaires qualifiés sont institutionnalisés et reçoivent un salaire, une motivation à la fin de chaque mois. Et donc, cette plateforme qui est en train de développer et va être intégrée va permettre à ce qu'on puisse générer le service fait, la présence au poste, les états de paiement et procéder au paiement de ces acteurs. À titre d'exemple, nous avons déjà au niveau du pays 2 millions de ménages qui ont déjà été embarqués dans sur cette plateforme avec plus de 14 000 relais communautaires et près de 600 agents de santé communautaires qualifiés qui utilisent au quotidien cette plateforme avec beaucoup de succès. Nous avons comme cette innovation, le cœur même, c'est la décision et l'engagement politique qui a permis à ce que cette politique de santé communautaire qui est innovante, révolutionnaire, puisse être utilisée pour toutes les campagnes et les activités de routine au niveau de la communauté. Ça offre l'avantage que, puisque le relais communautaire est identifié par la communauté et s'occupe de 200 ménages qu'il voit une fois par semaine, il y a le capital confiance qui est créé. On n'a plus besoin de mobiliser des ressources pour les former parce qu'ils sont déjà formés, ils ont la tablette, ils ont la plateforme et ils l'utilisent. Donc il suffit juste d'ajouter des modules spécifiques et les entraîner à faire le travail. Et ça permet à ce qu'aujourd'hui, dans toutes les zones sanitaires du pays, cette politique soit étendue. Nous avons 77 communes, il y a 75 qui sont couvertes aujourd'hui. Il ne reste que 2 grandes villes, Cotonou et Porto-Novo, pour lesquelles on étudie les spécificités liées à ces mégapoles pour pouvoir les embarquer. Et donc, si on prend la santé communautaire aujourd'hui, en s'appuyant sur ça, ça permet vraiment de connecter toutes les interventions et de disposer rapidement des données de qualité par rapport à ce qui se faisait jusqu'avant 2023. Alors, lorsque vous utilisez cette plateforme en routine, ça permet le suivi des ménages parce que le relais communautaire, lorsqu'il fait sa descente, sa visite à domicile, il informe directement à travers la plateforme et ça peut permettre de générer à la fin de chaque mois son rapport d'activité et mesurer les indicateurs de performance au niveau de la communauté. Lorsqu'on l'utilise pour les campagnes également, les différentes composantes de la campagne sont embarquées pour l'ONCO, l'administration des intrants d'ivermectine, mais également la gestion du stock, la supervision, la formation. Tous ces aspects sont embarqués et permettent vraiment d'avancer. C'est pareil pour toutes les interventions qu'on développe aujourd'hui. Le ministère de la Pêche et de l'Agriculture, on veut l'embarquer également dans cette politique parce que c'est une approche One Health et donc toutes les campagnes qui sont organisées également à ce niveau passeront par cette plateforme. Nous avons vraiment trouvé que c'est une politique innovante qui offre des avantages énormes. Et c'est le lieu ici de préciser que avec cette plateforme, il n'y a plus une différence de vue dans les régions parce qu'on a une harmonisation efficace des outils et de la stratégie de développement des activités, que ce soit de routine ou pendant les campagnes de masse. Ça permet également d'optimiser les ressources humaines parce que les relais communautaires sont permanents. Les agents de santé communautaire qualifiés sont permanents, ils sont dans la communauté, donc pour chaque campagne, nous ne faisons plus de recrutement de nouveaux acteurs pour pouvoir les former. Et donc ça permet à ce qu'on puisse renforcer la qualité des interventions au niveau du pays avec un coût d'opportunité qui est énorme. À titre d'exemple, les 5 dernières années avant cette campagne, on a dépensé environ 200 000 $ pour les coûts opérationnels des activités de routine, alors que toute cette politique, pendant le premier cycle de 7 ans, va coûter moins de 150 000 $. Donc ça permet de faire une grande économie d'échelle. La gestion des données est plus fluide, on a une promptitude, on a une complétude. Ça permet à ce que chaque soir, on puisse, pour les campagnes, discuter des données, donner les orientations, ajuster les orientations et les instructions. Et pour les activités de routine, à la fin de chaque mois, tous les décideurs peuvent apprécier la performance du système de santé au niveau communautaire. Nous avons également des défis au niveau de ce système innovant qui est en cours d'implémentation au niveau du pays. Le premier, c'est le transfert de compétences parce que c'est une plateforme qui est développée en collaboration avec Dimagi, donc il faut capaciter les acteurs nationaux à prendre le contrôle de la plateforme, les gérer, héberger la plateforme et surtout assurer la protection des données individuelles parce que nous avons toutes les informations des ménages qui sont embarquées dans cette plateforme. Il y a également le défi d'interopérabilité avec le DHIS2, comment s'assurer que les données de routine pour la santé communautaire, les données de campagne soient capitalisées directement dans le DHIS2 et puis le souci de pérennisation. Et en termes de pérennisation, il y a un engagement fort au niveau du gouvernement pour que les ressources domestiques soient mobilisées pour assurer l'entièreté de son financement après le premier cycle de 7 ans. Nos perspectives actuellement par rapport à ce système digitalisé est d'intégrer toutes les autres interventions au niveau des ministères One Health, que ce soit au niveau de l'environnement, au niveau même de la sécurité, pour que lorsqu'on veut mener une campagne ou des activités spécifiques à connotation santé publique, que ce soit cette plateforme qui soit utilisée. On est en train de développer, après le paiement à succès des acteurs pour la campagne, de développer le paiement des acteurs de routine à la fin de chaque mois à travers ce système. On veut également introduire l'intelligence artificielle dans cette plateforme parce qu'on va élaborer des messages interactifs pour interagir avec les bénéficiaires et les ménages sur des problèmes de santé spécifiques. Il y a également le volet géolocalisation qu'on veut intégrer pour que à tout moment on puisse savoir qui fait quoi, qui est là, qui est venu au niveau du ménage, qui est sorti, ainsi de suite. Et puis le tableau de bord intelligent qui est en train de se développer pour faciliter l'appropriation des décideurs. Donc voilà un peu ce que nous sommes en train de faire au niveau de la santé communautaire qui est maintenant au cœur de toutes les interventions de santé communautaire et de santé publique au niveau du Bénin. Merci beaucoup.
Merci donc beaucoup à Rodrigue. Nous venons de suivre deux très bonnes présentations. Avec la première présentation du Kenya qui nous a montré un chemin parcouru depuis la mise en place des politiques jusqu'aux résultats qu'ils ont obtenus. Et puis après, il y a une présentation très très intéressante du Bénin qui nous présente une intégration qui ne va pas seulement intégrer les différentes interventions de santé publique, mais qui a une perspective d'aller au-delà du secteur de la santé. Alors donc sans perdre du temps, parce que nous avons eu une communication un peu longue du Kenya, qui a pris un peu le temps que nous aurions eu pour les discussions. Donc je vous appelle à applaudir d'abord très fortement ces deux intervenants. Nous allons prendre des questions maintenant et des commentaires pour tirer les meilleurs profits de ces communications. Alors, si vous avez des questions, je vous prie de lever la main pour que je vois combien il y a de personnes qui veulent intervenir. Alors, je vois qu'il y a beaucoup de mains, donc je vais commencer par ma gauche. Et je prendrai une série de 6 questions. On verra bien si on a le temps de prendre une deuxième série. Et donc, je vais prendre une question ici. J'ai vu deux mains, mais je prends une main ici. Et puis, je prendrai une main au maximum par table pour commencer. Allez-y.
Merci beaucoup, Joris. Ma question, c'est pour le Bénin. Merci aussi pour les présentateurs. Le dernier slide parlait de pérennisation. On sait que c'est un sujet assez, pas délicat, mais difficile, n'est-ce pas? Quelles sont les réformes en termes de politique que vous comptez mettre en place pour justement assurer cette pérennisation? Vous avez parlé de mobiliser les ressources domestiques, mais concrètement, quelles sont les réformes que vous envisagez de mettre en place? Merci.
Deuxième question. Oui, allez-y au fond.
Merci beaucoup. Je voudrais féliciter d'abord les présentateurs et je vais adresser ma question par rapport au Bénin à M. Rodrigue. Donc, on sent une dynamique d'augmentation de capacité communautaire au niveau du Bénin par rapport en fait à l'intégration de toutes les interventions à travers une plateforme unique. Et ma question, il y a une stratégie derrière pour équiper le flux des interventions, surtout particulièrement avec les supports pour la digitalisation ici, si je vais être bien clair, l'aspect des tablettes ou bien des téléphones. Ou allez-vous bien combiner les deux ou êtes-vous en suffisance du matériel? Merci.
Merci. Oui, au milieu, derrière, là.
Merci bien. Je voudrais très sincèrement féliciter les deux présentateurs. Donc, je disais que je voudrais féliciter les deux présentateurs, mais plus particulièrement la présence du département ministériel du Bénin. et votre présentation m'a beaucoup fait plaisir. Je voudrais poser une petite question. Comment vous êtes arrivé à surmonter un tel défi pour nous autres pays où nous avons le PNLP à part, les autres à part, mais vous êtes arrivé quand même à fédérer tout cela. Votre présence témoigne de la réussite, mais je pense que ce serait bien que vous nous dites comment vous êtes arrivé. Est-ce qu'il y a une volonté politique jusqu'au niveau présidentiel pour que vous puissiez arriver à de telles réussites, ou c'est l'implication du ministre de la Santé qui a fait le déclic? Et dernière question avec votre permission, est-ce que vous envisagez aujourd'hui de passer à la CPS en routine, vu que vous arrivez à faire d'autres campagnes avec les agents de santé communautaire tels que les campagnes de distribution de médicaments contre l'onchocercose? Est-ce que vous envisagez de passer à la distribution, à l'administration des médicaments de la CPS en routine avec les mêmes acteurs? Merci bien.
Alors, il y avait une main de... Oui, voilà, allez-y.
Merci beaucoup. My question is to the Kenya team. For the distribution, I understood that you use the fixed point strategy. So, did you do an evaluation at the end of the campaign to assess those who you did not cover or had to reach? Is this among the challenges that you did not anticipate, as you mentioned before? That's all from my first side. Thank you.
D'accord. Je vais prendre au fond de la salle, à droite, là-bas. Oui, allez-y.
Ok, merci. Merci. Ma question va à l'équipe du Bénin. Par rapport au nouveau modèle de santé communautaire qui est assez ambitieux et qui prend en compte un aspect assez important du côté digitalisation. Je voudrais savoir quelle est la part du gouvernement béninois dans le financement de cette santé communautaire et particulièrement aussi pour la digitalisation. Et en termes de pérennisation, qu'est-ce que ça pourrait donner? Voilà, merci.
Une dernière question, il n'y a pas une main devant à ma droite? Sinon, Allez, au milieu là-bas, madame. Oui, allez-y.
Thank you so much for both of your excellent presentation. And I have a question for the Kenya team. So you mentioned the sustainability and resilience in your speech. And I think these are both two very important aspects. So my question is mainly about the early warning and the real-time data. So I want to ask, in your system now, do you have to integrate the environmental or the weather data in your system so that we can do the early warning or response during the floods or the extreme weather events? Or if you do not integrate, do you have this plan to integrate this data? Thank you.
Merci. Alors, je vais laisser d'abord les intervenants répondre à cette première série de questions. Il y a eu 4 questions pour le Bénin, en fait 5 pratiquement, et 2 pour les Kenya. Alors, vous pouvez allumer vos micros pour répondre d'où vous êtes. Allez-y. Bénin, vous pouvez commencer, et puis après le Kenya.
Merci beaucoup à tous les collègues pour vos pertinentes questions qui dénotent de l'intérêt que vous avez accordé à la présentation du Bénin. Il faut dire que la santé communautaire a été hissée en termes de priorité de santé par le gouvernement du Bénin. Depuis 2016, il y a eu des réformes qui ont été effectuées. On a identifié les insuffisances au niveau du secteur et les interventions à développer s'inscrivent sur 11 axes. Et parmi ces 11 axes, nous avons la santé communautaire. Et donc, l'engagement politique au plus haut niveau a facilité le développement de cette politique. C'est une réforme qui a permis à ce qu'on puisse dire, oui, nous allons tendre la main aux partenaires, mais il faudra que, 1, on contribue, 2, on s'assure qu'après un premier cycle de 7 ans de mise en œuvre, que le financement soit totalement domestique. Et pour cela, le gouvernement s'est engagé non seulement à créer une ligne spéciale santé communautaire qui est approvisionnée d'environ 2 millions de dollars chaque année, avec une augmentation progressive de 15% chaque année pour permettre à ce que, après un premier cycle de 7 ans, que les ressources domestiques soient suffisamment mobilisées pour financer entièrement cette politique. Et nous sommes en avance par rapport à la tenue, au respect des engagements du gouvernement, parce qu'aujourd'hui, le gouvernement finance la politique à hauteur de 26 millions environ 26 millions de dollars, alors que théoriquement, nous sommes à la deuxième année, on devrait être autour de 4 millions de dollars. Ça montre comment, au plus haut niveau, il y a eu cet engagement. C'est une politique qui est suffisamment discutée au niveau du Conseil interministériel qui implique le ministre de l'économie et des finances et tous les ministres du One Health. Ça permet à ce qu'on puisse présenter les résultats et attirer l'attention sur les défis. Par exemple, nous avons un financement de l'USAID qui est très conséquent, qui accompagne la mise en œuvre, la mise à l'échelle de la politique dans 22 communes sur les 77. Avec la décision américaine de suspendre le financement, on a réuni le gouvernement en urgence qui a cherché à mobiliser d'autres ressources, que ce soit des partenaires, mais également le financement domestique, pour prendre le relais, pour financer ces communes afin de ne pas connaître de hiatus au niveau du financement de cette commune. De ces communes. C'est une politique qui est entièrement digitalisée. Nous utilisons des tablettes pour les relais communautaires et les ASCQ. Donc le pays a approvisionné les 14 000 relais communautaires de tablettes. Chaque relais a une tablette. Au départ, il y avait une insuffisance parce que les capacités techniques n'étaient pas adaptées. Ça faisait qu'il y avait de bugs et donc avec Dimagui et les partenaires, nous avons au niveau du comité de pilotage défini les spécifications techniques des tablettes, et maintenant les tablettes qui sont acquises et qui sont mises à la disposition des acteurs communautaires sont suffisamment strong pour permettre à ce qu'on puisse collecter les données au quotidien et analyser ces données et les transmettre. Ça fonctionne en offline pour permettre à ce qu'au niveau des coins reculés ou mal couverts par les réseaux GSM, que les données soient conservées, et quand ils sont dans un espace couvert par le réseau GSM, ils puissent les synchroniser pour qu'on puisse avoir les données. Et ce paramètre est également pris en compte par le gouvernement qui a assigné au GSM l'obligation de couvrir totalement le territoire afin de faciliter la mise en œuvre de cette politique. C'est dit combien de fois l'engagement politique peut faciliter la mise en œuvre d'idées nouvelles, comme le Kenya l'a montré dans sa présentation. Et donc, oui, les défis sont nombreux, mais avec l'implication du politique et du président de la République, ça permet à ce qu'on puisse les surmonter. C'est d'ailleurs pour ça qu'actuellement, nous avons préparé un décret qui va être signé et qui va permettre à ce qu'on crée un fonds unique santé communautaire indépendamment des sources de financement. Et donc, vous êtes un partenaire, vous voulez financer la politique de santé communautaire, vous envoyez les ressources au niveau de ce fonds, quitte à ce qu'au niveau pays, maintenant, on les répartisse sur les communautés. Et on engage également les gouvernements locaux, les mairies, à intégrer ce financement de la santé communautaire pour qu'après les 7 années, elles puissent prendre le relais. C'est pour ça que le gouvernement augmente sa part de financement des communes pour la santé communautaire. Aujourd'hui, toutes les campagnes sont intégrées, y compris au niveau des autres secteurs. La discussion est en cours pour que ce soit essentiellement ce système qui est mis en place qui soit utilisé. Et donc, l'ambition est de faire des économies d'échelle. Les campagnes de masse qui sont faites aujourd'hui, à partir de 2027, vont être routinisées pour que lorsqu'il y a un besoin ressenti dans une communauté, dans un ménage, on n'attende pas 3 ans pour organiser, ou 1 an pour organiser des campagnes et faire les distributions. Donc ça va être une distribution de routine, y compris pour la CPS. Donc voilà les questions qui m'ont été posées. Merci beaucoup.
Merci. Kenya.
So thank you very much for your questions. So for distribution, Kenya did use the fixed post distribution, and so nets were being collected at that level. So there are 2 ways that we ensure the hard-to-reach communities were able to collect their commodities. One, in as much as we had the fixed post, we also had mobile posts. Like on a first day, you do the distribution in the post, then the second day, you'd move the post to an area where people are if they're not able to come for the commodity. And we used donkeys to ferry the nets to those hard-to-reach communities so that they were able to be reached. So we ensured everybody was reached. Then the other method was, in terms of distribution, we were cognizant of the fact that not everybody will be at home during the collection, or if I was registered and it's my identity card that was going to be used. So what we had a system in place whereby you could collect for a neighbor. What the neighbor would send you with their identification details. Of course, this is in consultation with the local community leaders. So they'll bring their identity card, and so when you're distributing the nets, there were 2 options that were coming, prompts that were coming, that if it is self-collection, you issue that net. If it's being collected by a neighbor, they also give their details in terms of their mobile number and their identity number. And then a message is sent to the owner of the nets that your nets have been collected by so and so, and these are the details, so that you're able to ensure that if people are not able to come, there's someone who can come and collect as many nets, so long as they have that details, and that information is relayed now. It's the way a banking system works, that if someone operates your account, there's a prompt that will come to you, so that you're able to know that your nets have been collected. So those were the 2 areas we ensure that, so that everybody were able to collect their nets. On the sustainability, yes, we were getting the real-time data in terms of a household registration. And so if a community health volunteer had 100 households to take care of, so based on like registration, if your first day, your performance based on your first day, we can tell whether you'll be able to complete the registration within the stipulated time, because there were areas where the terrain was not favorable, the weather was not favorable. So that gave us, an warning that certain areas they might have challenges in terms of registration. And so we'll see in some areas we had even to extend the registration process. Thank you, noted. So, sorry for that distraction. Yeah, so again, so if you're registering, the community health promoter who is registering, we're able to track and know. And in fact, there are some areas we had to extend, because the system was set in a way that you open registration on a certain day, you close it after 5 days. But now, with the alerts you are getting in terms of how they are performing, and from the dashboards, you're able to see whether to extend. And the same case happened for distribution. So then for commodity, of course, though we ensure that after registration, the data was near accurate in terms of how many nets were being delivered to a certain post. So, but if there was anything in terms of how the commodity was being tracked, we were able to know if there are challenges in terms of that commodity reaching, if the allocated quantities are being dispatched, we're able to know whether there is any gaps, and we're able to address the same. And there are also plans now to link this system with the existing LMIS, so that we can see whether we can have early warnings for the commodities. Already in Kenya there's such a system that's happening, but how the next action is going to link the Digimal system with that, so that we can see whether that can help the country. I hope I got your question, but you can have more conversation on the theme. Thank you.
Je suis sûr que à la fin de cette session, pendant la pause déjeuner, il y aura beaucoup de questions qui vont être posées encore à nos collègues, mais pour la question de gestion du temps, je vais demander que l'on applaudisse encore très fort les deux intervenants et je vous invite à regagner vos sièges. Pendant qu'ils sont en train de regagner leurs sièges, je vais demander à ce qu'on se mette debout, hein, parce que je vois qu'on commence à être un peu lourd. Est-ce qu'on peut se mettre debout? Mettons-nous debout. Alors, est-ce que vous avez chacun ces blocs-notes de Movenpick devant vous? Vous avez ça? Est-ce que vous pouvez les tenir? Alors, tenez vos blocs-notes. Tenez vos blocs-notes. Tenez, je vais voir chacun avec son bloc-notes. Voilà. Voilà ce qu'on va faire. Nous avons une série de tables, d'accord? Il y a une première série ici, deuxième, troisième et quatrième à la fin. Ce que nous allons faire, c'est que partant de l'extrême gauche, ma gauche, hein, chacun va, en commençant par celui qui est au fond, va toucher le bloc-notes de son collègue, ok? Et puis lui, il va toucher les blocs-notes de son voisin. Le voisin touchera le bloc-notes de l'autre, les blocs-notes jusqu'à ce qu'on ait les derniers blocs-notes touchés. Et on verra quelle rangée va toucher le bloc-notes en premier. Vous avez compris ce qu'on va faire? Donc chacun va tendre son bloc-notes à son collègue et le collègue va ensuite tendre le sien au suivant et on verra qui arrive, quelle rangée va faire arriver le système de toucher le bloc-notes en premier au fond de la salle. Alors, est-ce que c'est clair? C'est clair? Alors, vous allez attendre mon top. Vous allez attendre mon top. Je vais dire 3, 2, 1. Allez-y. Waouh, je vois la première rangée. Après, applaudissons-nous déjà. Et puis, asseyez-vous. Je vais vous expliquer. Vous avez compris que pour toute chose nouvelle, il y a un temps où on explique, on met les directives en place, n'est-ce pas? Comme c'était le cas en 2017 pour le Kenya, en 2020 pour le Bénin. D'abord des directives, ensuite il faut les moyens, n'est-ce pas? Et puis après, il faut que chacun puisse adhérer. Et ensuite, on met en œuvre. Alors, si on met en œuvre correctement, on peut arriver rapidement à avoir des résultats. Il arrive que l'on ne se comprenne pas. J'ai vu ici des gens qui allaient dans tous les sens. C'est tout à fait normal. Et donc, voilà pourquoi gouvernance, c'est important, n'est-ce pas? Appropriation, c'est important. Et puis après, j'espère qu'il y aura une pérennisation. Si Marcy fait faire cet exercice en 2026, on va dire que ça devient périn. Allez, applaudissons-nous encore. Nous invitons donc, nous allons inviter les collègues du Soudan, Aweno, j'espère que je ne massacre pas le nom, Aweno, Norman, du Sud-Soudan, qui va nous parler des leçons apprises par le Soudan dans la distribution digitalisée des moustiquaires, donc Aweno. Nous invitons également Lorraine de Tchai, Lorraine, qui va nous parler des directives de l'OMS et de l'UNICEF pour la digitalisation des campagnes. Merci beaucoup. Donc je vais tout de suite passer la parole à notre collègue Aweno du Sud-Soudan pour faire sa présentation.
Yes, hello. Good morning, good afternoon. I believe you're all doing well. I would also implore those who are traveling today to make sure you've confirmed the time on your air ticket. Make sure that you don't miss the flight. I'm standing here to share learnings from the LLI digitalization in South Sudan. South Sudan hasn't been left behind. We are not known just for 7-footers and basketball, but we are also known for digitalization. And we are glad that we stand here to share from the previous campaign that we've had. What you're seeing right there is one of the community volunteers marking one of the households that has benefited during a digitalized LLI campaign. We haven't yet reached QR codes, but that is what we can also call a community-based QR code right there. I don't know whether I need some support to let this move. Could I get some support here? Ah, perfect. In terms of the background and context we're sharing here, long-lasting insecticidal nets in South Sudan is one of the predominant aspects or the backbone of malaria prevention. Of course, we have other mechanisms for preventing malaria, but when it comes to LLINs, we use them mostly because, one, they are more affordable, but also when you go to most of the households, you'll find that at least 63%, or call that 64% of households, at least can access a mosquito net, but also not just accessing, but we have 68% that are also able to use the nets. When it comes to distribution of the nets, they're primarily done by volunteers because we have structures in the communities, and those volunteers are the ones that we normally use to distribute the nets. But also, we've used this predominantly when it came to paper-based campaigns, but also during the digital campaigns. Because we don't want to be left behind, we have also prioritized digitalization, and we use that for distribution of nets, as we shall be seeing that a whole lot. But also our national malaria strategy is one that advocates a whole lot for digitalization right inside there. But also we are guided by the WHO, which has factored in a whole lot of digitalization when it comes to primary healthcare services and also public health concerns. Next slide. What are some of the challenges that we faced? And this is really before digitalization. A lot has been said during the entire week, and our challenges are not very different from different countries that have been sharing here. Of course, one of the challenges that we realized was, when it came to generating reports, there were delays because there was no instant synchronization of data. But also when it came to real-time monitoring of data, it was very hard because some of the locations that we work in are off the grid with internet. And so when it comes to real-time monitoring of data, it's very hard. The issue of data loss was very, very common, especially in the rainy seasons. Some of the papers or the registers would get washed away by rain, and so that would become a very big challenge. I did mention that also tracking net distribution was very hard because remember at that time, paper-based, there was no identification of households using the GPS coordinates. So when the third-party monitors came, it was always very hard to track the net distribution. Next slide. Our experience when it came to digitalization was very, very interesting. The conversations began by the Minister of Health taking lead. And when the Minister of Health took lead, we also came on board as Malaria Consortium to support them in this particular initiative. So this initiative for digitalization was one that was started by the Ministry of Health, and so we did support them on that particularly. We went ahead and piloted 2 PIAMs. We at the community, the structures are in such a way that you have the village, which we call a boma, and after the boma we have the PIAM, then we have the county, the state, and then the national level. So we began by piloting 2 bomas in Central Equatoria. Based on the outcomes from the piloting, which was successful, we scaled up. We scaled up to the entire Central Equatoria, but we also scaled up to 4 other states. South Sudan has 10 states, so 5 states are covered by digitalization. The process also was one that was supported by a partnership with the HIFS Tanzania, who worked hand in hand with HIFS South Sudan, but also with especially the HMIS department in South Sudan, offering capacity, strengthening, and also real-time solutions. The Global Fund and Action Against Malaria were at the forefront based on their recommendations. They did advise that the campaigns take up a digital approach based on the challenges that were registered from the paper-based. The entire process was one that was led by the community structures from micro-planning, but also going into aspects of community mobilization, making sure that the communities are very much aware about the campaign, but so that no one is left behind. Next. Some of the uniqueness or the innovation aspects that we did see with the digitalization campaign, some of these other countries have spoken about. We had the opportunity for online troubleshooting. In our framework, what we did, with the support from the National Ministry of Health, they were also involved in the campaign, and many of them were also involved in the field. And so when there were challenges, they were able to address those challenges at record time. We opted for marking households like we saw in the first slide, making sure that households where GPS capturing GPS failed, at least if a volunteer was in that very community, they would not end up doing double counting or double distribution of nets. South Sudan has a challenge about access to electricity is about at about 8.4%. And so it was always going to be a challenge, the communities, the volunteers using tablets in terms of charging them. So what we did, we linked volunteers to established health communities that have solar, and so when their batteries would run out, they would at least go and charge freely. We made sure that for purposes of sustainability, that was done. But also in the particular towns, we made sure that particular charging booths were identified, where the volunteers will also go and charge their tablets. The offline mechanism, of course, was very important for us, which was linked to the DHIS instance. Especially, they would collect their data, and the volunteers would collect the data, and subsequently they would synchronize when they had access to internet. Next. Collaborations were very important for us. In the process, what we did, and with the guidance of the National Ministry of Health, there was a technical support group that was formed. This primarily was led by the HMIS, and also people from the National Malaria Control Program, and other technical persons were incorporated into this technical support group, and these were very instrumental in addressing challenges, especially at real time. We also learned the hard way, and we had to strengthen our collaboration with security agencies. When it comes to utilization of tablets, we found that sometimes the security agencies thought we were spying probably on some facilities. So we had to make sure that we entered a collaboration with them, explain to them about the campaigns, which was very helpful. In one of the instances, I remember some of the tablets were confiscated by the security agencies, but thankfully the National Minister of Health was able to come to rescue, to retrieve them back. But also we made sure that there was a coordination mechanism that began from the national level, that cascaded down to the lower levels at state level, down at county level, at Payam, as well as the Boma levels inside there. And various people were involved, from the commissioners to people at the State Ministry of Health were very much involved and very much helpful. Going down to the CHD or the county health department, those were all involved. I did mention about collaboration with the HISP Tanzania. That was very important, especially when it came to development and application of the application, as well as capacity building. South Sudan has benefited greatly from HISP Tanzania. Even currently, where they're supporting us to develop, where they've supported us to develop another digital tool. During the process, there was a task force that was established that had various technical people from the HMIS, National Malaria Control Program, of course, Global Fund, the funders, AMF, and also the country coordination mechanism. Where they would also be able to access data at real time, and where there were queries, they were able to address those queries, or were able to address those queries that were raised with them. So there was accountability, open accountability. Next. Improvement in the campaigns, especially when it comes to planning and implementation. What we noticed, because we've done paper-based as well as digital, we did notice that there was strengthened accountability. Many countries have also spoken about this, where monitoring the campaign is pretty much easier, distribution very much easier. But also we made great use of the dashboards during the campaigns, and those were very much helpful in terms of tracking performance, which areas are lagging behind, how can we re-strategize. That was very much helpful. The bottom-up approach was very instrumental for us, making sure that there is ownership right from the community level. And so we did involve the local structures very much, right from the village level, or what we call the Boma level, which is the lowest administrative level. The chiefs were very much important, sometimes when it came to identification of community volunteers, because we didn't want to get volunteers from different locations. So that one was very much helpful for us. But also, what we believe in terms of improvement is data that has been generated can be used subsequently for future campaigns. Planning for the next campaign data is already being used from the previous campaign. Ability to track nets at household levels while utilizing the GPS is very instrumental, or was instrumental, or improved greatly. The achievements resulting especially from digitalization. Of course, we noticed that there had been strengthening of capacities of volunteers and supervisors, and thankfully these remain in the communities. It's not like they are taken away. So those can always be leveraged on when it comes to different campaigns. The successful scale-up that I did touch on a little bit to now 5 states, that's a great success. The ability to track using the GPS we believe it was successful. But also very key for us was ownership from the National Ministry of Health, taking lead in terms of core design processes. That was very much instrumental for us, especially using the human-centered design, especially for the tool, to make sure that it is easily applicable. We distributed nets, of course, to 2.7 million. 2.7 million nets were distributed to 4.5 million people. In terms of, I did touch a little bit about access to real-time data. For us, that was very important, not just at the national level. data being used even at the state level was very significant, because at the state level we also have focal persons for malaria who are able to access that information, people who are responsible at the state level for data that is entered into GHIS2. So they would use that for planning in terms of addressing areas that have been left behind. We also did realize that there was improvement in decision making, especially when it came to handling of logistics, reallocation of nets, and gap filling, especially for areas that had been missed out or households that had missed out. The data has been useful for planning for the next cycle, which is a great success as well, especially in terms of the population that using the data concerning the population that received the net. Accuracy has improved greatly, but also that comes because a lot of time was spent training the volunteers, and thankfully many of them really had the capacity to even retain the information. Of course, there were challenges, like any other campaigns, there were challenges, especially when it comes to low human resource capacities. There was a lot of turnover. Some volunteers would walk away because the expectations in terms of monies was a little bit higher. Digital literacy is still an issue in South Sudan, in Africa, I must say. Of course, logistical challenges, those were pretty much there, especially in the rainy seasons. When it rains in South Sudan, it floods quite a lot, and so maneuvering becomes a big problem. Hence, having longer campaigns. Of course, system challenges, such as poor internet. Only about 12% of the rural areas can access internet, so it becomes a very big challenge. Many times they would have to walk to a particular spot where there is internet, where they have to synchronize the data. Insecurity, of course, a very big challenge for South Sudan. But we managed to navigate all of those by especially involving the security agencies, making sure that they are aware about the campaigns. Next. There were lessons that were learned in terms of the process. What we established down the road was, majority of the volunteers, about 94% of the volunteers agreed that the digital tool was an improvement from the paper-based. Thankfully, most of them that had been working on the paper-based were integrated on the digital instance. So they did notice that there was a significant change. Of course, despite the challenges, they also said digital tools, they preferred digital tools compared to the paper-based, according to them. Especially when users also found the tools helpful for managing workflows, as well as reducing workload, supporting stock management, and campaign monitoring, where you don't have to rely, at the national level or for the campaign to end to go back and track. So that was very instrumental in terms of lessons learned. Of course, the predominant one is including security organizations. That is one thing that we had left out in the beginning, but we believe it's a very key lesson learned to make sure that they are on board. When it came to DHIS2 review, or what you call event reports, and the LLN, what we found inside there was tracking nets particularly. It was very fast. Some of my friends here from the National Ministry of Health can ascertain that. They found it very, very fast. And sometimes they would not wait for feedback from the team in the field. They're able to track from wherever they are. So that is something that we found very, very much helpful, that not just one person can track, but anyone seated anywhere. Sometimes we had donors actually tracking the campaign and giving us information even before we reach out to them, which we found very much helpful. As we summarize, next. The recommendations. We have some recommendations that were generated. We believe that we would want to see multi-sectoral collaboration, especially, and as well as robust structures. And this one, we're talking about active participation of the private sector. We believe that the private sector should be very much involved in some of these campaigns. I've seen some of my colleagues from other countries where the private sector has been involved, especially when it comes to mobile money payment. We believe that that's one of the areas that we can pick on as South Sudan. But also we do believe that there's need for a working digital strategy that would guide especially health implementation in South Sudan. So that's something that we need to embark on as soon as possible. There's a draft, but that needs to be completed as well. As much as there's a structure available, there's need to localize some of the regional structures as well to make sure that, to secure especially digital health investments, because there's a lot of investment that has been done when it comes to digitalization. So there's need for continuous improvement of those localized structures, not just at the national level, but cascading down at the state level, so that we don't always rely on the national level to come to our rescue, but to make sure that some of the glitches can be managed at the lower levels. There is a very huge need to co-opt the private sector, include them in the planning processes and the roadmap development. Many times we've left them out, yet we can leverage on their capacities, on their resources, especially now that funds are dipping almost across the world. Next. Yes, we believe that there is also need to localize as much as possible, especially when we want to see sustainability. And this has to do with continuous strengthening of technical capacity to address gaps. But particularly here, we're looking at HIPS, South Sudan taking lead in the efforts. So we would want to see a whole lot of involvement of the HIPS South Sudan, since most of their capacities have been developed, because it helps to decrease the turnaround time to address gaps. Strengthening regional frameworks is something that we want to continuously keep doing because it helps us to address issues, record turnaround. But also we believe one of the ways that we can strengthen capacities is connecting local talents to to organizations, whether international organizations, so that they may get more skilling, so that they can be able to use the expertise to improve their capacities. Last slide, I think. And then the very last recommendation is to support government-led advocacy for sustainable and improved ownership of health digitalization efforts. Currently, when it comes to funding health in South Sudan, the government funds almost 4% of the health budget, which is quite very low. We would want to fund more definitely as a government, but we believe that we can improve. So there is definitely need, if we want to see more digitalization, that the commitment really has to go higher than just less than 5%. But also to ensure the LLIN campaigns, digital campaigns are part of the broader digital health strategy. That is something that must continuously be preached across all the departments as well, especially for purposes of efficiency. And lastly, to plan for a scale-up. There's a lot of learning that has been attained, and we believe that scaling up nationally would be effective but also efficient. We saw from many presenters here how it is more efficient to use digital compared to paper-based. So that is what we would love to see. Lastly, there is a research that we carried out next slide, the last slide, that looks at the LLIN distribution. That's a QR code for anyone that is interested in terms of finding out more of the findings. I want to acknowledge our very key partners who are here, and that is one of our main architects, that's Matur. Matur is the lead HMIS architect at the National Ministry of Health, and who was behind especially supporting the development and the implementation of the digital LLIN campaign. Colleagues, thank you for your ears.
Alors, quelles sont les orientations de l'OMS et de l'UNICEF? Nous allons inviter Lorraine pour nous faire sa communication.
Thank you. I am Lauren Tice, and I support the Clinton Health Access Initiative, it's a digital health team. We will be, in this session, trying a triple hybrid approach. I am joined by my colleagues, Chipo Gongoni from the WHO Afro region, as well as Christina Luciana from UNICEF. And so our teams in recent years, along with we've collaborated along with many individuals and organizations represented in this room, actually, to synthesize and package guidance on the integrated digitization for campaigns. This has been built from lessons learned, best practices from the broader integrated campaign digitization community, from experiences sharing campaign devices, solutions generally, applications, as well as integrating with routine health systems. And so we will be speaking more about that. This session specifically will introduce the Integrated Campaign Digitization Toolkit, which was recently released, as well as the upcoming Digital Solution Selection Guidebook for health campaigns. After this session, or after lunch specifically, we will also be facilitating a breakout session that will discuss the benefits and practicalities of what it takes to integrate digitization across multiple campaigns. And so we hope that you will join us. But to kick off the full presentation right now, I will perhaps ask for some support in playing the pre-recorded presentation that we have from Chipo.
Good day, colleagues. My name is Chipo Ngongoni, and I'm an innovation specialist under the WHO African Regional Office. Last year I was with you in person to give you an overview of the Integrated Campaign Digitization Toolkit, and today I am here to proudly launch. Good day, colleagues. My name is Chipo Ngongoni, and I'm an innovation specialist under the WHO African Regional Office. Last year I was with you in person to give you an overview of the Integrated Campaign Digitization Toolkit, and today I am here to proudly launch that toolkit. If we're looking at the relevance of why we actually built this toolkit, we're looking and hearing our member states lamenting issues around having an end-to-end comprehensive approach to digitization, looking at how we can have integrated platforms across multiple disease areas to reduce fragmentation, the reuse of digital assets across campaigns to make sure that we are resource-wise, and we are also looking at our resources properly, to enable the government to have more control and ownership over their digital tools which are being utilized in the countries, and to ensure that we have the digital and the data aspects in place in terms of interoperability and strengthening the national digital health infrastructure. So currently the toolkit is in two pillars. One is operational. So we have two guidances. The first guidance is around governance. So basically looking at what do we term good governance for a governance structure for looking or overlooking integrated campaign digitization. what do we talk about when we say we are digitizing a campaign? What are the important aspects to look at in terms of stepwise? The other aspect is the monitoring, evaluation, and learning framework, which is very important when it comes to just following up the level of impact that we have in digitizing these campaigns. Last year, we had a discussion of whether it was even worth it to digitize campaigns. So this is one of those aspects we're trying to answer. The second pillar is on technological aspect. So this is the reference architecture. What is an ideal reference architecture? Looking at how would you select products for digitizing your campaigns, and also the functional business requirements across different use cases in digitizing campaigns. Currently, we still have some other additional guidances in progress. So firstly, we have the hardware management guidance, looking at answering questions around how do I integrate bring your own device in digitizing campaigns, since we see more and more usage of electronic devices by our central data collectors and aspects like that, as well as looking at how do we have centralized management of that. Secondly, we have a campaign digitization costing guidance tool, where we are looking to say what are the cost benefits of actually implementing. Can we project something in terms of saying before we even implement a tool, how can we project to make sure that these campaigns are actually worthwhile to digitize in the first place? Just to give a refresher on the methods that we used in the toolkit development process, this stemmed from our technical working group, which we are opening up to you to please join us. It's a technical working group for experts working across different contexts in campaign digitization. And we did the situational and landscape analysis in our pilot countries, which were 2 Francophone countries and 2 Anglophone countries, to make sure that we can understand the dynamics around it, because we know that one size doesn't fit all in this context. We also shadowed campaigns and gathered insights in these pilot countries, as well as conducting key stakeholder workshops and meetings to get feedback around this, around our technical working group, around to make sure that we're in the right direction. And we also had expert feedback when we were now finalizing the toolkit. So we reached out to communities of experts, some of you are sitting in the room, to give us feedback on this toolkit. As we know, knowledge is not static. So we believe in co-creation. We believe in making sure that we ask the community what aspects are important. So when it comes to this toolkit and the development and ongoing development of it, because we don't even say we've stopped here, we are asking you for input. Firstly, what's missing? What do you notice when you do access our toolkit? What do you see as something really missing, which you have struggled with when it comes to digitizing campaigns? Secondly, do you have any success stories or lessons learned that we can actually exemplify and share with the community, which is very important because visibility is something which lacks in this area of health campaigns. Thirdly, which dissemination strategies would ensure that this guidance goes to the right stakeholders? Yes, you are primary stakeholders, but you deal with other stakeholders. So how best can we do this? We have thought about also translating this. So an upcoming version is coming for a French translation of the guidance, but we also want to see what other avenues can we tackle to make sure that we address all aspects. And our fourth aspect is how best can we better tailor these learnings and recommendations to diverse country contexts. So definitely one size does not fit all. We are saying let's work together to make sure that we learn from each other. We recommend things which are practical and which are usable. We don't want to just create a toolkit that sits on a shelf and is not utilized. Then that's pointless and futile, isn't it? So above all, overall, thank you, obrigado, and merci.
toolkit. And the intended target audience is represented by the program teams that are involved in the health campaign, and especially at the country level. So the Digital Tool Selection Guidebook wants to answer 3 different types of user needs. So first of all, what if a user wants to understand the digitization of health campaign phases? So for sure, there is the WHO Integrated Campaign Digitization Toolkit that does that. And we have provided a section in the guidebook that talks about this. Then, what if a user wants to compare digitization within a campaign phase, and or if a user wants to view the functionality of one tool, one individual tool across all campaign phases. So taking this in mind, we have organized a guidebook around these 3 different types of user needs. So, of course, we had to come up with some selection criteria for the Digital Tool Selection Guidebook. So, at the moment, we are including free and open source solutions and digital public goods. So, this is not set in stone, because we also recognize that there are many tools that are a good fit for supporting digitization of health campaigns, and they are not free and open source solutions, neither digital public goods. So we are open to review the selection criteria in future versions of the guidebook, and we will really love to have your feedback on how to expand the guidebook, including more tools than what we currently have. So, as Chipo has introduced, so in the Integrated Campaign Digitization Toolkit, WHO has mapped all the different phases of campaigns, and they've also identifying how does the workflow work across the different phases, and what's the role of digital tools in each campaign phase. And they've also mapped the different campaign phases against campaign stages, campaign planning, campaign execution, and campaign monitoring and responses. So in the selection guidebook, we have basically taken these workflow, and for each campaign phase, we have identified the goal, as already stated in the WHO ICD toolkit, the use case for digitization, essential business workflows. I mean, what in this specific phase, what are the business workflows for this specific phase, and what are some opportunities for digitization. And we have done this for each campaign phase, so that it's immediately clear how digital tools can actually support with these specific campaign phases. Then, within each campaign phase, we have taken a step further, and we have added the tool layer. It means, okay, for this specific campaign phase, which are the tools that are supporting the workflows and the opportunities for digitization. So for this, we have come up with a list of indicators that are specific to each campaign phase. For example, here on screen, we have the campaign phase enumeration, and some of the indicators of this campaign phase are related to the feature of conducting field enumeration of non-geolocated objects, or conducting field enumeration of geolocated objects, and so on. So for each indicator, we have 3 different types of scores, whether the tool fully supports this feature, this indicator, partially supports this feature, or this feature is not supported by the tool. So we have reached out to 20+ product teams to provide inputs according to their knowledge, according to the tool capabilities, on whether the tool actually supports, partially support, or not support each feature as identifying for each campaign phases. So this is still in a draft format. We are still receiving inputs from the product teams and furthermore receiving inputs from the user community to validate the inputs from the product team based on real world experience. And we hope to finalize this inputs gathering process in the next couple of weeks. And so for each campaign phase, we've basically come up with these tables where we have the tools and then the indicators, the features supported for each campaign phases. Then we have also looked at things the other way around. So here we are developing cards for each tool, for each individual tool, and then we are mapping the tool functionality across all phases. It means that instead of looking at things by campaign phase, here we are looking at things by tool. Here on screen we have a draft version for the tool access mode, and here we are basically combining all the phases that are supported by this tool and how the tool performs against each indicator of the campaign phases. So the development of the selection guidebook has actually started in June of last year, where we had our first internal conceptual framework of the guidebook to respond to some user needs from some countries where they basically were saying, I'm using this tool for a supply chain, can I also use it to do something else? Or I want to digitize the payment component of campaigns. What tools can I use? And how does it fit within the national digital health ecosystem? So we have started drafting an internal conceptual framework, and then learning that the WHO was developing the WHO ICD toolkit, we have aligned the selection guidebook as closely as possible to the WHO ICD toolkit. Then, end of last year, we set on a final list of selection metrics indicators, and then we started our inputs gathering phase. As I've said, we gather inputs from several product teams, and I know that some of you are in the room, and we really appreciate the time and the effort that you put into providing inputs in the selection metrics of the guidebook. And then we are in the process of validating the inputs with the community, with the campaign utilization working group and other key informants, and we are still in this phase. So we very much welcome your inputs, and we hope that we'll be in a position to have a final version to share back with the product teams for their review in the next couple of weeks, and then a final publication and promotion will follow. So in case you are interested in contributing into the digital tool selection guidebook for health campaigns, I encourage you to scan the QR code, or you can also go to the link that is in the presentation when this will be provided to you at the end of the meeting. And we would love to have inputs from the communities on both the selection guidebook and the selection metrics that is part of the guidebook. Thank you so much. This is all from my side.
Alors, merci à l'équipe qui a présenté la boîte à outils. Merci à notre collègue du Soudan du Sud. Nous allons prendre quelques questions, sachant que nous sommes un peu à l'étroit par rapport au temps. On va récupérer les temps perdus du côté de la technique. Nous allons voir... On commence par ma droite cette fois-ci. S'il y a des questions, levez la main. Et on va terminer par la gauche. À ma droite, est-ce qu'il y a des questions, des commentaires? Je ne vois pas de main à ma droite. Voilà, donc je vais prendre ici et puis le collègue à gauche.
Thank you. On some of the guidance that's coming out, I'm interested to know if the integration with other tools is reaching deep into integration with both electronic logistics management information systems, or even ideally procurement systems. So we have this integration of product identification throughout the continuity of the program? Thanks.
Thank you. How does the guidance balance standardization, in terms of the scalability of the tools and the flexibility to adapt tools to local contexts, so resource settings and other factors? Thank you.
Y a-t-il encore une question dans la salle? Pas de questions supplémentaires. OK.
Sure, and I'm happy to start with those, and then I think if Chipo or anybody else or Christina on the line have additional comments, we can add those. I believe the first question was regarding integrating LMIS and procurement systems. The idea overall with this integrated digitization is not only to be able to share infrastructure and applications across different campaigns, but really also to integrate with routine systems. One of those routine systems ideally being an LMIS, ELMIS. And so there is guidance and recommendation basically to do that where applicable. Maybe speaking a little bit to the second question because it ties in, one of the modules of the toolkit is a reference architecture, technical reference architecture that provides input on and a structure to follow on how to really bring together different systems, whether it's your ELMIS, it's your registries, to connect them to those different applications or solutions supporting campaign workflows. So big picture with the toolkit, it's of course not one size fits all. There are numerous approaches that could be taken, and so these guidance documents really share best practices as well as some tools, for example, the upcoming costing tool that's included, that was mentioned, or some existing ones like the product selection guidance that really emphasizes putting together a technical working group, multi-sector, depending on what all is involved within your country, to make decisions that make sense for the country, for the campaign, for the program. And that is how we've tried to approach making sure that it can be applicable and really offers frameworks, but emphasizing governance and other decision-making processes.
Alors, nous allons encourager nos panélistes et nous allons applaudir abondamment pendant qu'ils vont regagner leur place. Merci beaucoup. Vous pouvez regagner vos places. Nous allons faire une petite... Ah, il y a encore une dernière main. C'est à l'intention des panélistes? La main. Un commentaire. Ok, allez-y.
Thank you so much for the opportunity. Mine is just an additional information to the presentation of South Sudan. Last year there was a presentation shared and published by Align for Malaria Prevention. It's available on the website. The presentation presented today by my colleague Owino is for Malaria Consortium. Malaria Consortium was one of the partners contracted by Minister of Health to do the distribution. So they have just presented the data from the state in which they carry out distribution. But according to our national database, we have distributed around 6.4 million nets, okay, benefiting around 15 million people with all these aggregations. We have up to 1.3 million under 5 that have benefited from the distribution, and around 789 pregnant mothers were also served during the campaign. The digital tool also helped us to do beyond just protecting people from malaria. We have used it as our national database, and we are concurring with the database of the National Bureau of Statistics in regards to the population, because we have never done a census, but we are just relying on the data that we are just collecting from the households and the estimates at the same time. So we have our tool available, and we can also share with the other people if you guys need to use the DHIS2 directly, and the other fishes which are actually inside the DHIS2, how we customize to our local contact and make it successful. So this is just a brief information that I just wanted to give. The next campaign, 2026, is going to be done digitally, and we are going to use the same tool, the same DHIS2, to do the distribution. So we'll also be reaching out to Ghana, Kenya, in regards to bring your own device approach to see how best we can adapt that and use it for our local contact. Otherwise, thank you so much.
Merci pour les commentaires. Merci aux panélistes. Vous pouvez regagner vos places. On va essayer de faire une petite synthèse de la session. Je vois du renfort en train de s'approcher.
Thank you very much, Dr. Joris. Please let's appreciate them. Okay, so I think we are getting there. We all seem a bit tired. Can I hear the voice? Hello? Okay, so we are going for a lunch break, and we come back here after lunch. We want to have a group photo as soon as we finish lunch. We've had a very wonderful 5 days meeting, and we don't want to leave without a group photo. So we are all coming back here to the stage as soon as we finish lunch, and after that we go into our workshop sessions. Once again, there are 4 sessions. The first one is the bring your own device, which is the use of individual owned devices for campaigns. And then the second one is the integrated campaigns and cross-program digitalization. The third one will be optimizing campaign data reuse, where we look at some of the data use as we've discussed in the past few days. Also how we can reuse the data for subsequent interventions and also for subsequent campaigns. Then we have the last one, which is on payment, so electronic or digital payment, how we can improve how we use digital tools to improve our payment. So when we come back, I think the first one will be at Baobab 1. Baobab 1, which is the room just outside. Please, you find signs or notices on all the doors where you are supposed to be. The other one will be also at Amasi 1. The second one will be here. Integration will be just this room. The workshop 3 will be Amasi 2. The data use is just at the back. So this room will be divided into 2. Some will be at the back and some will be here. And the last one, which is the payment, will be on the 5th floor. So there's a room on the 5th floor, but you have directions or signs showing you or directing you to where you are supposed to be. So on this note, I think we can all clap for ourselves again because we have done very well. Lunch is served, so we can all go for lunch and return at maybe 2. 2 if you are, we can come back at 2 so we can close early today. So we come back at 2. Thank you. So we all come back here for the picture before we go into our individual workshop sessions. Thank you.